Cubaan suara.
Kita tarik bawah dulu.
Boleh? Boleh tarik kau?
Sebab kita nak tarik begini je.
Oh.
Okey, saya cuba bagi dia duduk dulu. Pengerdaannya.
Cubaan suara 1 2.
Boleh dengar.
Cubaan suara 1 2 3. Cubaan suara 1 2 3.
Boleh dengar saya ke? Saya Dr.
Tak ada
Aisyah.
volume macam ni. Ni.
Saya Dr. Aisyah, boleh dengar ke?
Dr. Aisyah, boleh dengar Dr. Aisyah?
Alright.
Boleh dengar? Assalamualaikum Dr. Aisyah, selamat pagi.
Waalaikumsalam.
Sorry, kita pun kat sini pun tengah diorang IT still doing the necessary arrangement. We're gonna start by 8:40 lah. The first remark coming from me.
Alright.
And then kita punya semua buat live kat sini.
I think
Display from here, you can see next.
I think better lah sebab kadang-kadang kalau kita buat sendiri little bit slow kan.
Okay, then I'll let the IT team know that you want us to actually control. You just say next, and we do on your behalf lah on that part.
Alright, great, thank you.
Alright, so
Hydrosin Aqua, the advanced wound wash, irrigation and debridement solution with a difference. Hydrosin Aqua is an advanced and comprehensive wound management product designed and manufactured under the proprietary New Water technology. Hydrosin Aqua is made of ultra-purified water and pure dry vacuumized sodium chloride, which goes through an electrolysis and superoxidation process developed by Vigilance New Water technology. Hydrosin Aqua, after going through a very controlled and stabilized processing, will finally yield hypochlorous acid, sodium hypochlorite, sodium chloride and water. When there is a wound, foreign contaminants or particles enter the wound. The natural body defense mechanism detects this breach and delivers red blood cells and neutrophils to the wounded area to combat against the invading pathogens. The neutrophils engulf the pathogens through a process known as phagocytosis. Hypochlorous acid, or HOCl, is a potent oxidant produced by activated neutrophils. This hypochlorous acid is electrically neutral, whereas the pathogenic cell walls are negatively charged. Therefore, the hypochlorous acid can penetrate the pathogen's cell wall and slime layer, creating an osmolarity difference in the cell. The pathogenic cell then swells and ruptures, leading to cell lysis. This is known as osmotic shock. Hypochlorous acid supports in the natural wound healing process with no toxicity to patients. Hydrosin Aqua is indicated for stage 1 to 4 ulcers, venous status ulcers, diabetic ulcerations, post-surgical wounds, first and second degree burns, bed sores and pressure ulcers. The benefits of Hydrosin Aqua are Hydrosin Aqua has been extensively tested in several recognized and accredited labs for its microbiological efficacy and biocompatibility safety, in compliance with principles of good laboratories practice (GLP) and/or ISO IEC 17025. Hydrosin Aqua is proven to be effective against a wide range of microbes. Hydrosin Aqua is biocompatibility tested in accredited labs according to the ISO 10993 international standard to ensure product safety. Hydrosin Aqua comes in various packaging options to suit various applications and needs. Hydrosin Aqua is classified as Class 3 medical devices under the EU Medical Devices Directive and Regulations. Hydrosin Aqua products have obtained the US FDA 510K approval for marketing in the US, CE certified and Halal certified. For more product-related information, please visit the following addresses.
Catheterization of a man. Gently pull back the foreskin so you can easily access to clean around the urethral opening. Remember that this hand is not sterile anymore after touching the patient. Carefully clean the area to avoid any hairs, textile fibers or other particles to enter with a new catheter. Anesthetize the urethra by completely filling it with anesthetic catheter gel. Use 1 gram gel per centimeter urethra, meaning that for a man you need approximately 20 to 30 gram. After filling approximately half of the amount of gel, wait for 1 minute so the external sphincter muscle is relaxed. Then fill the remaining amount of gel and let it work a little while before inserting the catheter. Using your sterile hand, insert the catheter gently. It shouldn't hurt. When you feel some resistance, the catheter has likely reached the external sphincter muscle. Be extra careful at this point. Insert the catheter all the way until the funnel junction. Get some urine in exchange before you fill the catheter balloon with the fluid and precise amount that the catheter producer recommends. Remember to constantly observe the patient. Also, this step shouldn't hurt. After you have completed this procedure, make sure that the catheter is positioned correctly and can move freely. Finally, attach a urinary bag or a valve. Change of a suprapubic catheter. To facilitate the procedure, it is preferred that the bladder is filled as much as possible, as the line from the entrance on the abdomen to the bladder itself becomes straight. Fill the bladder using sterile sodium chloride, maximum 3 deciliter, or until the patient feels the urge to urinate. Complete this stage by closing the catheter with a plug to prevent the fluid to back out. Carefully clean around the insertion hole to avoid loose particles or textile fibers to enter with a new catheter. Deflate the balloon that normally is filled with 10 milliliters of fluid, which is enough for most catheters. When the balloon is empty, take a note of how much has been withdrawn for later documentation. The next step is to remove the catheter, which sometimes can be a little challenging. Hold one hand against the patient's abdomen and gently pull the catheter with the other hand. A small cramp in the abdominal muscle might force you to take a little break in the process. Small talking to the patient to get them to relax can help at this stage. It is important that the patient feels as relaxed as possible. When the whole catheter has been removed, a little urine can appear, so it is advisable to put a cotton pad to keep the patient clean.
All right. Okay.
Now it is time to place the new catheter. As with urethral catheterization, there are different ways to enter the catheter itself in a sterile way. Remove the cotton pad and place the hand on the patient's abdomen.
Ada glitch pula pagi ni, tak boleh nak respon pula orang.
We advise to use catheter gel. In this case, it both prevents pain and lubricates for easier catheter insertion. Let it work a little while. Observe the patient while you're placing the new catheter to make sure he or she doesn't experience any pain. Get some urine in exchange before you inflate the catheter balloon. To avoid that the balloon is inflated in the abdominal wall instead of the bladder, make sure to enter it far enough. If you don't have a tray, as in this case, close the catheter with a valve immediately. Fill the balloon with 10 ml of the fluid that the catheter producer recommends. Remember to constantly observe the patient. This shouldn't hurt. Finally, pull the catheter slightly towards you so it has the right position. Feel that it can move freely. To protect the patient's clothes, you can put some protection around the catheter itself.
Okey. Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum semua pada pagi ini. Selamat datang ke the inaugural Military Safe Surgery Safe Life Seminar 2020. So saya Lieutenant Colonel Dr. Ahmad Tarmizi bin Muhammad, Pakar Berdaam dan Setiausaha Jawatan Kuasa program pada hari ini mengucapkan selamat datang dan selamat menonton kepada semua peserta the inaugural Military Safe Surgery Safe Life Seminar SSSL 2020. Pada hari ini kita bersiaran secara langsung daripada Hospital Angkatan Tentera Tuanku Mizan, Kuala Lumpur. Hadirin yang dihormati, SSSL 20 ini adalah inisiatif yang julung kali diadakan di peringkat Perkhidmatan Kesihatan Angkatan Tentera dan telah dirancang semenjak setahun yang lalu. Walau bagaimanapun disebabkan oleh pandemik COVID-19 dan ianya termaterai pada hari ini, setahun kemudiannya yang berjaya direalisasikan pada hari ini. Kita semua amat bertuah pada hari ini dan mengucapkan jutaan terima kasih di atas kesudian Yang Bahagia Ketua Pengarah Perkhidmatan Kesihatan Angkatan Tentera Malaysia, Lieutenant General Datuk Pahlawan Dr. Muhammad Amin bin Muslan di atas kesudian untuk bersama-sama dengan kita pada pagi ini untuk merasmikan the inaugural Military Safe Surgery Safe Life Seminar 2020. Kita sedia maklum akan kesibukan beliau dan kepadatan jadual Yang Bahagia Datuk, namun kehadiran beliau pada pagi ini membuktikan keprihatinan beliau dalam menyokong usaha untuk kita memberikan perkhidmatan pembedahan yang selamat kepada semua stakeholders. SSSL 2020 ini adalah kesinambungan daripada SSSL versi 2.0 yang dilancarkan pada tahun 2018, diterajui oleh Patient Safety Unit Medical Care Quality Section, bahagian perkembangan perubatan KKM dengan kerjasama SSSL Steering Committee KKM. Seminar pada hari ini menampilkan penceramah-penceramah, leaders dalam their field dan mempunyai pengetahuan yang amat mendalam tentang patient safety, terutamanya SSSL. Untuk sesi pertama pada hari ini, kita dibawa untuk memahami apakah itu inisiatif SSSL dan suka saya perkenalkan tiga penceramah kita pada hari ini. Brigadier General Datuk Dr. Muhammad Razin bin Kamaruzzaman, Head Corporate Safety Oversight Malaysia Airlines Berhad. Ceramah kedua dibawakan oleh Dr. Nur Aisyah binti Abu Bakar, pakar perubatan kesihatan awam, Timbalan Pengarah, Medical Care Quality Section, Medical Developmental Division, Kementerian Kesihatan Malaysia. Dan ceramah yang ketiga dibawa oleh Datuk Dr. Muhammad Anwar Haw Abdullah, Chairman SSSL Steering Committee, Kementerian Kesihatan Malaysia. Kita berterima kasih juga kepada rakan penaja program pada hari ini iaitu Vigilance Medical Devices Sdn Berhad. Dan kita hari ini ditonton secara langsung di seluruh pelosok negara dengan penyertaan daripada Hospital Angkatan Tentera Tuanku Mizan Kuala Lumpur, 96 HAD Pangkalan TLDM Lumut Perak, 94 HAD Kem Terendak Melaka, Hospital Angkatan Tentera Wilayah Kota Kinabalu Sabah, Hospital Tentera Darat Gemas di Negeri Sembilan, Institut Latihan Kesihatan Angkatan Tentera Insan Melaka dan Universiti Pertahanan Nasional Malaysia. Program juga dibuka kepada semua yang menonton melalui saluran rasmi YouTube Hospital Angkatan Tentera Tuanku Mizan. Program hari ini telah didaftarkan untuk koleksi mata CPD. Tetapi untuk memenuhi syarat mendapatkan mata CPD, mestilah menghadiri kedua-dua sesi pada sesi pertama hari ini dan sesi kedua minggu hadapan. Waktu yang sama, 19 Mac 2021. Untuk mendapatkan mata CPD, nanti peserta dikehendaki untuk scan QR code. Saya tahu pagi ini ada sedikit masalah untuk QR code kerana limit of response, tetapi nanti kita akan rectify dan saya akan maklumkan kemudian bagaimana untuk kita mendaftarkan untuk mendapatkan mata CPD. Ya. Baik, untuk tidak membuang masa, kita akan meneruskan acara kita pada hari ini dengan menjemput, dengan sukacitanya, untuk menjemput yang berbahagia Lieutenant General Datuk Dr. Muhammad Amin bin Muslan, Ketua Pengarah Perkhidmatan Kesihatan Angkatan Tentera Malaysia, untuk menyampaikan ucapan dan seterusnya merasmikan the inaugural Military Safe Surgery Safe Life Seminar 2020.
Terima kasih Lieutenant Colonel Dr. Tarmizi, pengerusi majlis kita pada webinar pada pagi ini. Ya. Terima kasih kerana jemputan ini bagi peluang saya untuk merasmikan satu webinar yang amat penting pada pendapat saya. Ya, saya mulakan teks ucapan saya dengan Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Yang berbahagia datuk-datuk pegawai merintah, ketua-ketua perkhidmatan, pensyarah-pensyarah jemputan yang saya muliakan, pasukan-pasukan pembedahan perkhidmatan kesihatan Angkatan Tentera, mereka di UPNM, mereka di Insan dan semua yang hadir. Bagi pihak Perkhidmatan Kesihatan Angkatan Tentera Malaysia dan Kor Kesihatan Diraja, saya mewakili seluruh warga mengucapkan selamat datang atau yang lebih tepat selamat log on kepada semua peserta inaugural Military Safe Surgery Safe Life Virtual Seminar 2020. Datuk-datuk, tuan-tuan dan puan-puan, seperti semua sedia maklum, seminar ini telah dirancang sejak awal tahun 2020 sebagai satu seminar berformatkan in person, di mana datuk-datuk, tuan-tuan dan puan-puan semua boleh duduk dan berinteraksi secara ilmiah di dalam dewan kuliah bersama-sama. Walau bagaimanapun, format seminar ini terpaksa diubah kepada bentuk hybrid di akhir tahun lepas bagi menyesuaikan diri dalam keadaan COVID ketika itu. Tetapi malangnya, ianya terpaksa ditangguhkan sekali lagi kerana masalah negara ketika itu sedang dilanda gelombang ketiga COVID-19. Kita semua terpaksa mengharungi tempoh darurat dan menumpukan perhatian kepada peperangan melawan ancaman COVID-19 ketika itu. Alhamdulillah, kita sekarang ini telah mula melihat penurunan kes dalam negara dan di serata dunia. Namun, kita masih dalam situasi PKPB. Saya berpendapat kita tidak boleh lagi menangguhkan seminar yang amat penting ini. Keselamatan pesakit dan keselamatan di Dewan Pembedahan bukan saja memberikan manfaat yang besar kepada kesejahteraan pesakit pembedahan, tapi juga akan memberikan lebih keyakinan dan kepercayaan terhadap kualiti perkhidmatan yang disampaikan oleh Hospital Angkatan Tentera khususnya dan Perkhidmatan Kesihatan ATM amnya. Justru, saya mengucapkan jutaan tahniah dan terima kasih kepada Ahli Jawatankuasa Safe Surgery Safe Life PKAT yang dipengerusikan oleh Kolonel Dr. Ngu Kee Siong dan Hospital Angkatan Tentera Tunku Mizan kerana telah berjaya mengadakan seminar ini walaupun ianya hanya secara maya atau virtual. Saya yakin walaupun kita tidak dapat berinteraksi secara bersemuka, dengan penggunaan teknologi ICT dan budaya baru ini, sikap ingin belajar dan minat dan kesungguhan para peserta serta pengkongsian ilmu dan pengalaman dari para pesyarah jemputan, seminar ini akan berjaya mencapai objektif yang telah ditetapkan. Komitmen, iltizam dan tindakan yang bersepadu dari semua pegawai pemerintah dan ketua perkhidmatan klinikal, jururawat dan staf sokongan sudah pasti akan dapat menghasilkan impak positif yang meningkatkan keselamatan pembedahan di Hospital Angkatan Tentera. Datuk-datuk, tuan-tuan dan puan-puan, dalam kita mengharungi cabaran pandemik COVID-19, perkhidmatan pembedahan juga mengharungi beberapa cabaran hebat. COVID-19 bukan sahaja mengancam kesihatan di peringkat komuniti, tetapi juga memberikan tekanan baru kepada perkhidmatan pembedahan di hospital-hospital Angkatan Tentera, dan pembedahan adalah tidak terkecuali. Pesakit pembedahan bukan sahaja terdedah kepada jangkitan komuniti, tetapi juga boleh dijangkiti penyakit COVID-19 dari kaki tangan hospital dan pesakit lain di hospital dan keluarga mereka. Pesakit COVID juga boleh mengancam pasukan pembedahan dan pembiusan di hospital dan akan mencemarkan Dewan Bedah dan ICU serta menyebabkan perkhidmatan kritikal ini menjadi tergugat. Di kesempatan ini, saya mengucapkan jutaan terima kasih dan penghargaan saya pada semua pegawai pemerintah dan warga pasukan masing-masing kerana tabah mengharungi cabaran-cabaran ini dengan cekal. Hampir kesemua Hospital Angkatan Tentera bekerjasama memastikan kepatuhan kepada SOP dan tata cara tambahan yang terpaksa diwujudkan demi keselamatan pesakit dan warga pasukan. Saya yakin kita semua akan bangkit, berjaya keluar dari kemelut ini. Kita semua akan menjadi lebih berpengalaman serta bijak dan akan menjadi warga kesihatan ketenteraan yang lebih tabah dan prihatin terhadap kepentingan penjagaan keselamatan pesakit dan warga masing-masing. Untuk semua, saya yakin kita boleh menang dalam pertarungan ini dan saya memohon semua warga PKAT untuk memilih mengambil vaksin COVID-19 yang telah disediakan kerajaan. Lindung diri dan kita juga akan lindung pesakit kita. Berbalik kepada perkara perkhidmatan pembedahan, ianya amat sinonim dengan perkhidmatan kesihatan ketenteraan. Peperangan sememangnya telah menjadi sejarah kemanusiaan dan kecederaan lazimnya adalah gejalanya. Satu masa dulu, kadar kematian akibat pembedahan di lapangan adalah amat tinggi sehingga 42% sewaktu peperangan revolusi di Amerika. Namun dengan pembangunan sains dan teknologi perubatan, kadar tersebut telah berjaya dikurangkan ke paras 10% di peperangan Iraq dan Afghanistan. PKAT telah melalui beberapa gelombang evolusi dari segi perawatan pesakit dan pemodenan infrastruktur kesihatan. Perkhidmatan pembedahan ketenteraan juga merupakan komponen penting dalam evolusi pembangunan tersebut. Sejak tahun 90-an lagi, PKAT telah menghantar pasukan-pasukan pembedahannya untuk mengiringi kontingen ATM di Namibia, Cambodia, Bosnia, Timor Leste dan operasi khas di Laut Cina Selatan dan Teluk Aden. ATM juga telah menghantar pasukan pembedahan dalam misi-misi kemanusiaan di Pakistan, Indonesia, Filipina dan yang terkini di Cox's Bazar, Bangladesh. Di dalam negara, Hospital Angkatan Tentera Terendah suatu ketika dulu adalah hospital terawal yang telah berjaya melaksanakan pembedahan pemisahan sepasang kembar siam. Kini, hampir kesemua had telah berkembang dan boleh melaksanakan beberapa prosedur baru yang unik seperti laparoscopic surgery, pembedahan bariatrik, pembedahan kanser, pembedahan implan dan mungkin tidak lama lagi pembedahan transplantation. Sekiranya aspek-aspek keselamatan pesakit tidak dititik beratkan, keupayaan-keupayaan melaksanakan pembedahan-pembedahan ini mungkin akan menjadi ancaman baru kepada pesakit sekiranya pembedahan tidak dilaksanakan dalam situasi yang selamat. Datuk-datuk, tuan-tuan dan puan-puan, Menurut Pertubuhan Kesihatan Sedunia, rawatan pembedahan biasanya merupakan kaedah rawatan untuk mengurangkan kesengsaraan pesakit dan menurunkan risiko kematian akibat kecederaan, jangkitan kanser atau patologi-patologi tertentu. Walaupun prosedur pembedahan bertujuan untuk menyelamatkan nyawa dan mengurangkan kesengsaraan, kaedah pembedahan yang tidak dilaksanakan secara selamat boleh mengancam nyawa. Prosedur pembedahan lazimnya boleh membawa beberapa implikasi atau komplikasi seperti berikut. Pertama, kadar kematian selepas pembedahan besar atau major surgery secara kasarnya adalah dalam lingkungan 0.5 sehingga 5%. Kedua, komplikasi selepas pembedahan untuk pesakit di dalam hospital atau inpatient boleh berlaku pada kadar sehingga 25%. Ketiga, di negara-negara maju dan membangun, hampir separuh daripada semua komplikasi pesakit hospital adalah berkait rapat dengan prosedur pembedahan. Keempat, sekurang-kurangnya separuh daripada komplikasi yang dilaporkan boleh dicegah. Dan kelima, kematian disebabkan pembiusan am atau general anesthesia boleh mencecah nisbah 1 kematian untuk setiap 150 pembiusan di beberapa kawasan di benua Afrika. Berdasarkan implikasi-implikasi tersebut, Pertubuhan Kesihatan Sedunia telah mengambil langkah proaktif bagi menangani masalah keselamatan pembedahan. Inisiatif Safe Surgery, Safe Life adalah bertujuan untuk meningkatkan tahap keselamatan perawatan pembedahan seluruh dunia. Ianya adalah teras piawaian keselamatan pembedahan yang patut diguna pakai oleh semua pihak yang menyediakan perkhidmatan pembedahan di hospital dan di klinik. Di Malaysia, konsep Safe Surgery, Safe Life sudah diterapkan dalam amalan perawatan pembedahan kebangsaan sejak Januari 2010. Sebagai salah sebuah institusi kesihatan awam negara, Perkhidmatan Kesihatan Angkatan Tentera juga turut serta dalam mengimplementasikan amalan Safe Surgery, Safe Life ini. Inisiatif ini terkandung sebagai salah satu komponen dalam Malaysian Patient Safety Goal yang turut menjadi sasaran PKAT. Datuk-datuk, tuan-tuan dan puan-puan yang berkhidmat di Dewan Bedah Hospital mungkin sudah biasa menggunakan dan mengisikan borang Safe Surgery, Safe Life atau borang SSSL ini. Selain menggunakannya sebagai checklist atau senarai semak bagi tujuan kehendak piawaian kualiti hospital, saya ingin mengajak anda semua untuk turut sama menghayati falsafah dan prinsip keselamatan pembedahan yang menjadi asas kepada pewujudan borang tersebut. Penekanan kepada falsafah keselamatan pesakit ini adalah amat penting. Ianya bagi mengelakkan tata cara mengisi borang menjadi amalan rutin harian di Dewan Bedah yang kelak kemudiannya akan melahirkan warga kerja perawat yang alpa terhadap kepentingan penjagaan keselamatan dan penjagaan pesakit. Perlu diingatkan bahawa skop keselamatan pesakit pembedahan adalah lebih luas daripada borang tersebut. Justru penghayatan terhadap aspek keselamatan ini boleh dimanfaatkan oleh semua melalui seminar yang julung-julung kali dianjurkan untuk PKAT pada kali ini. Berdasarkan personaliti penceramah jemputan yang tersohor dan topik-topik menyeluruh yang dalam aspek patient safety, saya yakin semua lapisan warga PKAT dapat mempelajari dan menghayati konsep Safe Surgery, Safe Life secara holistik dan menjadikannya sebagai aspek penting dalam penjagaan pesakit mereka. Dengan lafaz Bismillahirrahmanirrahim, saya dengan ini merasmikan pembukaan the inaugural Military Safe Surgery, Safe Life Seminar 2020. Stay safe, patuhi SOP COVID-19 dan semoga kita berjumpa lagi. Assalamualaikum.
Terima kasih Yang Berbahagia Datuk Ketua Pengarah Perkhidmatan Kesihatan Angkatan Tentera Malaysia, Lieutenant General Datuk Dr. Muhammad Amin bin Muslan kerana sudi merasmikan majlis kita pada hari ini. Untuk tidak melengahkan masa, izinkan saya perkenalkan penceramah pertama kita pada pagi ini. Beliau tidak asing lagi di dalam Perkhidmatan Kesihatan Angkatan Tentera, seorang yang dikenali ramai sewaktu beliau berada di dalam Perkhidmatan Angkatan Tentera. Yang akan saya perkenalkan adalah Brigadier General Dr. Muhammad Razin bin Kamaruzzaman, Head of Corporate Safety, Oversight and Aviation Medicine, Malaysia Airline System. Beliau merupakan seorang pakar perubatan awam yang mempunyai kelayakan akademik melalui Aviation Medicine, Master of Aviation Medicine from University of Otago, New Zealand, Health Administration from Eastern Michigan University, dan juga Diploma in Aviation Medicine from King's College London. Dan beliau pada hari ini akan bercakap kepada kita berkenaan dengan the Swiss cheese model in patient care. Untuk tidak melengahkan masa, saya mempersilakan yang berbahagia Datuk Dr. Muhammad Razim bin Kamruzaman.
Bismillahirrahmanirrahim. Thank you very much, Mr. Chairman, yang dihormati Lieutenant General Datuk Dr. Muhammad Amin bin Muslan, Chairman of KKD, as well as the Director General of Ministry of Health. Director General of Armed Forces Health Services. Yeah, when you go into the civilian, you think of Ministry of Health. Fellow speakers, Dr. Aisha, as well as Dr. Anwar, and the organizing committee. Thank you for having me here for this session, and it's an honor and a pleasure to be invited back among fellow friends in the system. Okay, I've been given the task to talk about the Swiss cheese model in patient care. As much as possible, I will try to attend this. Yeah, next slide, please. Okay, so it's really is my personal opinion. It's not Malaysia Airlines policy. I will just share. I have to put in disclaimer in this. Next slide, please. My scope of presentation is with regards to an introduction of the overall safety culture, as well as how aviation safety management is, as well as the Swiss cheese, and hopefully we can come to a conclusion. Yeah, next slide, please, Liana. Yeah, that's the scope of presentation. I like this picture of the Airbus 380 along with our Sukhoi 30. It reflects my practice as an aviation medicine practitioner all this while. Yes, next slide, please, Liana. So why do the healthcare sector behave differently towards safety compared to aviation sector? In my view, it's just that it is a cultural thing and organizational thing, how we are brought up, how we are taught, and how we practice in our day-to-day. But I find that the healthcare system has realized this and are moving in the right direction. Okay, one of it is having this safe surgery, save lives, and the policies that's been set, and so on and so forth. So in aviation, when things go wrong, it goes horribly wrong. Yeah, and it's not only the passenger who demise, but also the crew themselves. So that's why the pilots and the cabin crew are very safety conscious, because every time the flight takes off, it is their lives as well. It's not only about the passengers' lives. And in terms of practice, again, aviation pilots are about bringing person A to B from one point to the other. Yeah, a lot of preventive measures, safe measures, and so on. In the healthcare system, most of us, yeah, are consequence manager. Somebody who has a lump, somebody fractured a foot, somebody who had a heart attack, and so on. So a lot of us are mechanics to repair all this, rather than mechanics to prevent the body from being damaged. Yeah. So when you talk about health management, economics, health economics, and so on and so forth, it's actually probably allocation of preventive measures should also be considered. And finally, it's about education, partly creating awareness, but also about formal education of safety in the organization. In our case, in the healthcare system, I know some moves been made. University Malaya has started some safety training for their undergrads. Yeah, I'm sure it will cascade down through the whole system, the nursing school, the ancillary school, and this also should be in the postgraduate school. It doesn't have to take many hours, but just basics. So how is aviation governed? In the whole aviation world, we are governed by the Chicago Convention 1944. And with that, we have annexes and standards and recommended practices. Yeah, or in short, it's called SAPs. And because of that, we are signatory to the Chicago Convention. We have Civil Aviation Act 1969, and it cascades down as the Malaysian Civil Aviation Regulation 216. And with that, because of acts and regulation, all airlines and operators are bounded by this requirement. Yeah, the accountable manager, my group CEO, can be taken to jail if he is neglecting the safety aspects of operations. Okay, and like I mentioned, it can be catastrophic for an aviation industry. One A380 carries 4 pilots, 20 cabin crew, and you can fit up almost 500 passengers. The other aspects is from the health as a point of view. Yeah, it's about patient care, and most times is one-to-one. Yeah, and the governing body is World Health Organization, but World Health Organization is more of a, just like ICAO is a technical body which advises countries and member states on the best practice. WHO introduced the safety surgery surgery checklist in as recent as 2000. Yeah, and last year, 2 years ago, they introduced the World Patient Safety Day on 17 September 2019. At Malaysian level, maybe Dr. Aisha can correct me. What we have at present is a Cabinet Directive 2003 on the formation of Patient Safety Council. And the question is whether we are enforced to have a patient safety management system. Unlike aviation, it's already there. We have to have a safety management system. But in the healthcare system, do we have a patient safety management system? Most catastrophic, probably a pregnant lady with 6 babies in her, and a gynecology procedure or obstetric procedure gone wrong. One mother and potentially 6 babies lost. That's what I can think of. Yeah. And from the workers' perspective, we are governed by Occupational Safety Health Act 1994, the Factory Machinery Act 1967, as well as the some organizations have adopted the Occupational Safety Health Management System, which are audited and accredited and so on. And this is more to cater for workplace injury or death. Next, please, Diana. Okay. All right. So again, why safety? Yeah. Easy way of putting it is about accident, injury, or death prevention, while at work or anywhere. And in terms of the health aspect of occupational safety health is monitoring of the hazards exposed to prevent a worker from getting illness due to the hazard exposure. The present one is a biological hazard which gives us COVID-19. It's not only at workplace, it's at community at large. Yeah. So as an organization or as a system, we are obliged to our people, to our environment and sustainability, to our asset as well as to our reputation. So those are the general broad principles why we do this. Okay. Right. Okay. Just to introduce about safety culture. Yeah, what is safety culture? It's basically a set of values, beliefs, perceptions, behavior of the organization towards safety. The challenge is when nobody is looking. Yeah. So used to have a advertisement years ago, yeah, during just before the World Cup, and so one of the soda pop company came up with makan bola, tidur bola, minum bola, lakukan bola, and things like that. So how we think, how we talk, how we act, how we behave on safety, on ourselves as a culture, even without thinking. We go into a car, we put on the seatbelt. We ride a motorbike, we put on the helmet. We go anywhere, we wash our hands, And if we see a trip wire, we may sort of raise a report and put a tape across it so that nobody trips and so on and so forth. Yeah. So in terms of components of safety culture, it needs strong leadership. No doubt about that. There's strong leadership commitment, leadership presence, leadership examples, and most importantly, leadership accountability. You know, because the leaders have the authority, have the resources to pump in money, create new organizations, and create programs or whatever towards safety. But it's not only leaders, it must have some workforce commitment as well. Not some, workforce commitment as well, which is the followers need to be in sync with what the leaders want in terms of safety. Not only safety, everything, yeah? Business and whatsoever. So to guide and manage the safety, you should have a safety management system, which I will share a bit more. And the 5 elements of safety culture. James Reason not only talked about Swiss cheese model, he also talked about the 5 elements of safety culture, which is an informed culture, a reporting culture, a learning culture, a just culture, and a flexible culture. Right? And to do this, you will introduce the 5 E's of engage, educate, enable, empower, and to a lesser extent, enforce the system. Just to share with you a bit more on the, let's see if I can go my slides. Yeah. What is an informed culture? Yeah, informed culture is an evidence-based and actively disseminating safety information. We do that in our medical world, no doubt about that. Yeah, we write papers, we study, analyze data, come to a conclusion, and we publish our reports and share it worldwide. It's easier nowadays. Probably every day you get a news of COVID-19 nowadays, whether you can use ivermectin or not, whether Johnson & Johnson vaccine is a single dose and has its efficacy, and so on and so forth. Yeah. We also have the reporting culture, where everybody can report a hazard identification, something they find not right, or an incident without fear of being punished. Yeah. In my organization, this is very much sought after. It's a KPI for us, and on average a year there's about 6,000 safety reports, even without operations, even with operations at only 30%. Yeah, so these safety reports are analyzed and it's a closed loop system. At the end of it, the person who reports gets back the feedback of what has been taken on the safety report. Yeah, it's also about learning culture. Yeah, healthcare system is a learning culture, no doubt about it. We share with each other, but sometimes our learning culture can be very in silo. The surgeons talk about surgery, the urologists talk about urology. I'm taking on Mr. Ngu here. Yeah, the ophthalmologists talk about eye, but sometimes there's no common platform. So, but this is a common platform. Safe surgery, safe lives is not really about surgery. It should be about the healthcare system. Yeah, just culture. This is something that's very difficult even in the aviation industry, where a line is drawn between what is error, which is acceptable, and what is violation, which is not acceptable and will have consequence management if needed. Yeah, so people who make error are not punished, but people who violate are punished, to simply put it that way. And finally, a flexible culture, a culture that adapts to the changes but goes through the proper risk assessment, proper management of change, proper risk assessment and risk management. You see it in the aviation industry now, even in healthcare system now, of the changes due to COVID-19. Yeah, there will be organizational changes, there will be equipment introduction changes, there will be procedure changes, and every introduction of a new thing will have to go through a management of change and risk assessment and risk management. Okay, can we go to the next slide? Yeah. So where do we wish to go with this safety and safety culture? Okay. The proponents of aviation safety, Patrick here, introduced the 5 steps or 5 levels of safety. Pathological is the organization doesn't care at all about safety, you know, incidents or accidents or anything going wrong is either swept under the carpet or is neglected or not looked into. Reactive is, yeah, when something happens, we look into it and we make the corrective action, not necessarily the corrective action measures and so on and so forth. Yeah. Calculative, we use evidence and data, yeah, to prevent things from happening. We're seeing that in most organizations now. We are becoming less reactive, but more calculative and preventive. Proactive is, like I said, where everybody knows their role in safety and reports in things before things happen. Yeah, and the ultimate one is generative, where without even saying anything, the first business of the morning is safety. Yeah, all the safety checks are in before we start our day. Next, please. Okay, coming to the actual Swiss cheese. Yeah, Reason and Orlandella, his partner, introduced this way back in 1990. It's called also the cumulative effect, and it's modeled for accident causation in the aviation industry. For those who are not aware, James Reason is a psychologist and practiced in Manchester. Yeah, so he talks about layers of defense preventing accident, and when there are gaps in this layer of defense, normally there is a band-aid solution to it. You know, we are seeing trip wire, or let's talk about a good example of it is a pothole. Yeah, a pothole on the road in front of the A&E. What's the hazard there is the pothole. What is the risk there is a bicycle going into the pothole and somebody falling and breaking their neck. Yeah, and what do? We patch up the pothole. But do we actually analyze why this pothole happens? Maybe not. Yeah, is it the materials of the road surface? Or is there budget? Is there a preventive program to look into potholes where we resurface every 6 months or every year, and so on and so forth? You know, so so when those are aligned, yeah, an accident happen. Okay, the accident itself needs to be investigated and also needs to find the root cause and corrective action, preventive action, and to be shared, and it should be a closed loop to prevent future recurrence. And it is a system approach. It's not a individual approach. It's the why, it's not the who. Next, please. I think I've got 10 minutes to go. Bear with me. I've got maybe another 5 or 6 slides. Yeah, I'll give you an example of an aviation accident in my industry, or incident. Okay, from the bottom, yeah, an incident or accident occur. The root cause is the bee enters and blocks the pitot tube. The pitot tube is something in front of the aircraft there. You see it's having its pitot cover there to measure the speed of the aircraft when it travels. Yeah, the aircraft needs to be traveled. The wind goes into the pitot tube. The sensor picks up and will tell the pilot what is the speed of the aircraft for the pilot to take off safely. The V rotate. Yeah. And if this pitot tube is not functioning because of a blocked tube, because of the bee, it can give spurious, inaccurate results. The pilot cannot decide the V rotate to take off. The pilot will abort the takeoff. And if it's a high-speed abort takeoff, you can end up with skidding off the runway, causing an excursion. And it's just like you braking on the road on a rainy day, and you might pin over and possibly break your necks and fracture your arms or trigger the what do you call it, the airbags in your car, right? Depends what car you use. So we go along the accident investigation. Why did this happen? When we find that the technician did not put on the pitot cover. And why did this happen? We find out that the technician is not aware of the requirement of the new SOP to put a pitot cover at a particular aerodrome because there's a lot of bee activity. And why did this happen? Because the SOP was not fully circulated to the aircraft technicians by the line managers. And why did this happen? The new SOP, due to COVID-19 aircraft long-term parking, was rushed for release. So as we go along, we find that it's not the person, it's actually the system. The system has not catered for a quick communication down the line and ensure that people down the line actually have read the new instructions and so on and so forth. So it's not who the technician who did not put on the pitot cover, it's actually why the communication was not cascaded down fast enough to the people on the ground. Next, please. So I'm going to share an example of healthcare. I just picked up this cartoon, yeah. I'm afraid these were complications. There were complications, yeah. Somehow the foot ended up on the right arm of the patient. So we need to go through that accident or incident investigation, yeah, and apply that just culture thing. You know, error is accepted. We do the root cause analysis, and then we make sure it doesn't recur, document it, record it, and make sure it doesn't recur. And you go up through the incident, accident, unsafe act, the various levels that's been explained by James Reason. Next, please. Yeah, so in a nutshell, busy slide here, the 4 layers of the Swiss cheese there. You have the accident and injury as a result of the accident. So you look at the red box there, we have the reactive as a result of the accident, and the same principles to be applied. It should be a non-punitive if it's an error, and consequent management if it was intentional, yeah. But then we do the factual evidence, the root cause findings, cause and contributory, and we make the recommendations and the corrective action plan, and also the corrective action measures and closure, and we share back this incident report or accident report. Is again why this happened and not who. So we want to prevent the recurrence, yeah. On the yellow box, yeah, is to plug up the holes, yeah, failure or absence of this defense mechanism. Again, what it needs to be done is a proactive, preventive, non-punitive. You don't punish people for reporting a safety hazard, yeah, or small safety incident. Should be voluntary and should be closed loop. Again, hazard identification, you report and acknowledge, you do the risk assessment, you do the root cause, corrective action plan, corrective action closure, accept the closure, and give feedback to the reporter. So this will plug the holes, yeah, not corrective measure, but the whole gamut of root cause and so on and so forth. The most difficult one is when it is a human behavior, yeah, when person becomes forgetful or person becomes intentional in their, or becomes reckless in their practice. So in our system, we have a confidential human information incident reporting program where the reporter without fear can report on the unsafe act or unsafe behavior of a fellow colleague, and this is treated confidentially. And the receiver, normally a senior ranking person, will have the ability to call the person and have a chat and say, look, you are reported, you are doing something that is not acceptable, or you are doing something which is at-risk behavior, and we would like to coach you on this so that this doesn't happen again. Yeah, It is a challenge. It needed a 1978 crash, Pan Am KLM crash for this to start, crew resource management and so on and so forth. And I'm sure some organizations, some healthcare organizations have started this confidential human incident reporting program as well. Next, please. In the interest of time. So this is about just culture. You can Google this, Sydney Decker. Yeah. The red line is drawn between errors and at risk and reckless behavior or malicious behavior. Yeah. One is to accept and console and coach. The other one is to introduce consequence management. Next, please. So in our system, like I said, we do open reporting. Yeah, on average, about 5,000 safety reports a year, and it's a closed loop. Every safety report is catered to and is closed. Yeah. Next slide, please. Some examples, even bird strikes. It can be simple bird strike hitting the parts of the aircraft, but the catastrophic one could be a geese entering engines, causing engine shutdown. And you watch the movie Sali, yeah? The Hudson River crash water landing, right? Next slide, please. Is one of the other areas that aviation industry is particular, and this is a global thing, is the significant 7 risks, where can be airborne conflict, can be loss of control in flight. Yeah, the Sriwijaya crash recently, SJ182, was probably due to loss of control in flight. Control flight into terrain, yeah, flying into the mountains or the ground. Runway excursion is the common one nowadays. Runway incursion, smoke fumes, as well as ground safety incident. Those are the areas that we monitor using the safety management system. Next slide, please. Yeah, so what we have in our safety management system is a structure. It needs to be structured. You have to have department of trained people. You have to have policies. It has to be somebody who is accountable for it. You need to have process, documented process, as well as documented procedures. And the safety management system encompass few areas. Next slide, please. Yeah, 4 pillars of safety policy: safety risk management, safety assurance, as well as safety promotion. Yeah, there should be a safety policy. There should be a program of hazard identification, open reporting, risk assessment, risk management. Should be a program of audits, and should be a program of cascading the safety information and promotion. In the interest of time, ladies and gentlemen, yeah. Next slide, please. Again, safety culture. Try to look into this in our healthcare system and improve on it. Yeah, if you don't have programs, maybe you could consider having a program. And this is one of the way forward. Yeah. I've learned a lot in the aviation industry, and I'm trying to cascade this and promote it in the healthcare system as well. Next slide, please. So, ladies and gentlemen, the Swiss cheese model in patient care. Yeah, what we have to do, if we don't have one yet, maybe we have to develop a patient safety management system where there's structure, there's accountability, policy, process, procedures. Yeah, we cultivate a safety culture, the 5 elements mentioned just now. Yeah, and we should, one of the big thrusts of a safety system is a closed loop reporting system where voluntary hazard reporting is welcome to plug the holes in the cheese. Yeah, and mandatory incident reporting is established. Yeah, and to address why and not who. And with it, you have to have the philosophy of just culture, as well as address the system and not the individual. Ladies and gentlemen, it's been a pleasure for me to be with you on this. I wish the organizing committee, again, thank you very much for inviting me here to share whatever knowledge I have. All the best in the future sessions. I'm available for question and answer. Thank you. To quote Alexander Pope, to err is human and to forgive divine. There's a book on this written by Kohn, released way back in the 90s, and it's an interesting read of patient safety and healthcare management system. Thank you very much.
Terima kasih kepada Brigadier Jeneral Datuk Dr. Muhammad Razim bin Kamal Zaman di atas ceramah yang pertama kita pada pagi ini, the Swiss cheese model in patient care. And seperti yang dinyatakan di dalam ceramah yang disampaikan sebentar tadi, identification of problem untuk kita rectify problem tersebut, checklist, dan biasanya sesuatu kesalahan yang berlaku biasanya bukanlah disebabkan oleh satu kesalahan semata-mata, tetapi lebih kepada seperti Swiss cheese model yang mana kesalahan itu adalah berlaku di banyak peringkat sebelum terhasilnya satu yang boleh mendatangkan endanger kepada keselamatan pesakit. Alright, untuk ceramah seterusnya, untuk Q&A ya, saya untuk buat masa sekarang ini, sebab Datuk Razim untuk terpaksa meninggalkan kita sebentar lagi. So saya buka untuk sesi Q&A untuk the next 3 to 4 minutes. Jika ada soalan boleh typekan di YouTube ya, di kawasan live chat ya, untuk kita tengok jika ada soalan. Jika tidak ada, untuk sementara waktu saya housekeeping announcement, sebab ada banyak masalah untuk scan QR code. Saya akan flashkan QR code sementara menunggu soalan masuk. So saya minta untuk kalau boleh snap dan cuba untuk scan dan daftarkan ya. Mohon untuk QR code kita besarkan untuk skrin. Alright. Okey, so far kita tidak mempunyai soalan-soalan yang lebih lanjut. Saya ucapkan berbanyak-banyak terima kasih kepada Yang Bahagia Brigadier Jeneral Datuk Dr. Muhammad Razim bin Kamal Zaman. Dan seterusnya kita teruskan program pada pagi ini untuk SSSL 20 untuk penceramah seterusnya. Izinkan saya perkenalkan, kita akan bersama dengan Dr. Nur Aisyah Abu Bakar, Deputy Director Medical Care Quality Section, Medical Development Division, Ministry of Health Malaysia, Head of Technical Secretariat, Patient Safety Council, and also Steering Committee of SSSL, Ministry of Health Malaysia. So, Dr. Nur Aisyah adalah consultant public health physician dan very passionate about improving patient safety through policies, programs, capacity buildings, leadership, creativity, and engagement. She one of the main contributors for patient safety unit in Malaysia, especially the establishment of Safe Surgery, Safe Lives program since 2009. And she has involved not only locally, but also internationally and global arena as an expert group in Global Patient Safety Network. And she has received numerous awards for her contribution. Her passion and commitment untuk patient safety in the country not only help us to achieve what is best for our patient, but of course we were trying to improve the next level, especially in our country Malaysia. So untuk ceramah seterusnya, Dr. Nur Aisyah akan memberikan untuk tajuk ianya The Burden of Misadventures in Perioperative Care. Saya persilakan Dr. Nur Aisyah Abu Bakar.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone. Colonel Dr. Ahmad Tamizi. Thank you so much for the very lengthy introduction. Thank you. And to Yang Bahagia Lieutenant General Datuk Pahlawan Dr. Muhammad Amin bin Maslan, Ketua Pengarah Perkhidmatan Kesihatan ATM, the organizing committee. Thank you for inviting me today, and also congratulations for organizing this webinar. I think it's very, very important, and looking at the program is very good. So I will try to stick to the time. Thank you to Datuk Razin for really stick to the time. I try to do so for Datuk Anwar. Right, okay, can I have my slide, please? Right, today I'm going to talk on the burden of misadventures in perioperative care. Okay, next one, please. Right, before I zoom down to safe surgery, I just would like to talk briefly on patient safety, because patient safety is the principal objective of healthcare, mainly is to do no harm to our patient, ensure benefit of treatment outweigh the risk, and improving patient safety is very important because it is our ethical responsibilities as healthcare providers. It's also our moral responsibilities to patients and their families, and also an economic investment to invest on safety and prevent incident, because it costs a lot, even for Ministry of Health Medical Legals also it costs us lots of money. These are pictures of my boys, when they were many years ago, they were having tonsillectomy, one after another, and I can still recall the anxiety that I have, even though it was just tonsillectomy. So it's very important for us to make sure that our surgery is safe. Next one, please. Right, so patient harm is the 14th leading cause of global disease burden, and actually it is as bad as tuberculosis and malaria. And the most frequently adverse events were related to surgical procedures. So this is so it's very crucial to ensure our surgery is safe. Next one, please. Right, okay. This is actually the DG circular number 1/2020, the first one that Ministry of Health produced in 2020, and it's related to patient safety, making patient safety a main agenda in healthcare. And this circular actually came out following a World Health Assembly resolution that has been passed in 2019. It's about global action on patient safety. Next one, please. Right, so the 10 principles of global action plan on patient safety is here. I'm not going to elaborate the whole thing, but safe surgery is definitely under the number 8, integrating patient safety in our clinical program and healthcare service. So I that's is very, very crucial to integrate patient safety as part of our clinical practice. Next one, please. Right, this is just to highlight the huge number of surgeries that we conduct every year. Maybe last year and this year a little bit less because of COVID. I know many surgeries have been postponed, but otherwise in 2018 we conduct like almost 1 million surgeries in Ministry of Health hospitals. So, and it is estimated that the adverse event in the industrialized countries is actually about 3%. So it's very, very important to be proactive and prevent adverse event from happening. Next one, please. Right, so I'm going to share with you some statistics on wrong surgery in Malaysia, and this is actually based on Malaysian patient safety goals. And Datuk Razin mentioned this just now also, yeah. So Datuk Pahlawan Dr. Muhammad Amin actually mentioned this in his keynote address, yeah. So I would like to share with you some of the statistics. Next one, please. Right, so if we look at this, yeah, from 2013 to 2020, we had 37 cases, on average about 6 or 5 cases every year, yeah. Except for 2018, we had like 11 cases, yeah. And most of the cases are very much related to the orthopedic surgery, ophthalmology surgery, general surgery, as well as neurosurgery, yeah. Next one, please. Right. In terms of type of error, we can see that mostly actually due to wrong, is very much related to wrong side surgery, yeah, wrong side right, left, or left right, yeah, and then 5 wrong side, yeah, and then 4 wrong implant, yeah. We also had cases of unconsented surgery as well as wrong patient. Next one, please. Right. In terms of the number of cases, I mentioned just now, you know, the main ones are actually surgery related to the ophthalmology surgery, and then craniotomy. We had 3 cases of BTL as well, and 3 cases related to knee surgery, 2 cases on breast surgery. Yeah. Next one. Right. Now I will go briefly on the statistic related to unintended retained foreign body. For this one, I actually used the statistic from our Ministry of Health incident reporting system. For your information, in Ministry of Health, for the past 2 years, we actually started open reporting system, and this means all incidents need to be reported. Yeah, it's mandatory to report all incidents related to patient safety. Yeah, and this data is actually from our online incident reporting, or what we call EIR. Next one, please. Right, so we had a total of 125 cases of unintended retained surgical item, and about 82% actually actual retained surgical, unintended retained surgical item. Yeah, the rest are just near miss. Next one. Okay, when we want, if we look at the specific surgical item, mainly is related to instrument or instrument parts, gauze, throat pack, yeah, but that's not as many as gauze and instrument part. Yeah? We also had a part of needle, and then abdominal pack, guide wire, K-wire, swab, drain tube, and tampon as well. Next one, please. Right. Since 2018, when we started our new incident reporting system, we also collect the outcome of the incident, yeah, and fortunately, out of the 125 cases, only 3 lead to severe outcome. Severe outcome means that the patient require some sort of intervention, yeah. And the rest, 14, we had moderate outcome, 20 mild, and the rest no harm, fortunately, yeah. Okay, next one, please. Right, okay, I also would like to emphasize on the issue of improper or incomplete consent, yeah, because that also can lead to wrong surgery. Okay, so we are, I'm going to share some statistics related to this as well from our incident reporting system. Next one, please. Right, so for incomplete consent or improper consent, we had 145 incidents reported to us. Maybe some people feel that is small number. Probably it's just the tip of iceberg. I reckon that maybe there are more cases that have not been reported to us. Yeah. Right. So if we look at the what kind of issues related to consent, the main ones are actually wrong patient identification, wrong site and site return. Yeah. No consent at all. Consent not valid, or wrong procedure written. Yeah. Okay. Next one. Okay, that one just to highlight, some of the things related to consent. Yeah. Now I would like to share with you the incidents, real incidents actually, related to wrong surgery and unintended retained foreign body, just to give you some idea what's actually happening. Yeah, and this is very much related to what Dr. Razin explained in his presentation just now about Swiss cheese model. Yeah. Right, next one, please. Right, so case one, 68 years old gentleman with splenic fracture adenocarcinoma underwent left hemicolectomy, and during surgery, a gauze was missing despite thorough search and II assessment. Yeah, so they did a post-op. Patient was informed regarding the incident, and they did a serial X-ray of the abdomen, but they cannot find any foreign body. Nevertheless, the patient came again 4 months later with altered bowel habit and anemia requiring admission. So they did a CT restaging, and that actually showed a tumor at the anastomotic site with foreign body seen at the posterior stomach. Yeah. So they did subtotal colectomy and removal of the foreign body as well. So the recovery, fortunately, recovery was uneventful. Next slide, please. Case number 2, at 8:48 a.m., 1 year, 8 months old boy underwent examination under GA of bilateral ears and bilateral meningotomy and right gromming incision and adenodectomy. Yeah. And the extubation later on, after they finished, extubation was done, and prior to the extubation, the anesthetist already confirmed with the scrub nurse that the surgeon actually removed the throat pack. Yeah. So then patient was discharged to the day care ward, and then nevertheless, at 10:50 a.m., the patient was restless and impending respiratory collapse. Yeah. The patient was then sent to OT for examination of oral cavity and pharynx under GA, and true enough, they found the throat pack and removed. Yeah. Next one, please. Case number 3, I call it Swiss cheese model. Yeah. This is about 59 years old patient with bilateral knee osteoarthritis and was planned for right arthroscopic partial meniscectomy and also treatment injection. Yeah, and patient was sent to OT without site marking, and the team didn't check the consent properly prior to the surgery, and the site of the surgery was not written on the whiteboard. I think Mr. Anwar will elaborate on all these whiteboard stuff and things, yeah, after this. So the team was not attentive during timeout session. So basically it was probably just a tick, chartology or tick and tick session, yeah, and they did not check everything properly. So the surgeon mistakenly done the surgery on the left knee instead of the intended right knee. Yeah. Okay. Next one, please. Right. Okay. Case 4. One surgery is not enough. Right. Okay. This is about 64 years old patient with glaucoma and was planned for left eye implant under GA for advanced glaucoma. The patient admitted late on the day of surgery, and no marking was done before sending her to OT. So the marking was done in OT without confirming with the notes, yeah, and there was a last-minute change of team prior to the surgery, and the operation was not done by the surgeon who actually seen the patient initially. And also there were few problems and the team didn't concentrate during timeout. Again, the timeout was not done properly. I think for me, timeout is the last straw before you start your surgery. So it's really, really important to do timeout properly and check everything properly. So the surgeon mistakenly operated on the right eye instead of the intended eye. So after sending to the ward, the surgeon noticed that they actually had a mistake and the patient agreed for another operation to be done on the correct eye. So this should not happen at all. So that's why we need a checklist so that it can help us with making sure things are in order. Because we cannot rely on our brain solely. Right, next one, please. Case 5. Okay, this is about 70-year-old patient admitted with bilateral knee osteoarthritis, and they plan for right total knee replacement. And the patient admitted a day before surgery, and the site marking was done by the surgeon on the right foot. So it's on the right foot. Because they want to make sure they have the right side lah. So the consent for right TKR was taken. Unfortunately, they did a chlorhexidine bath given to the patient and the site marking faded. Next one, please. Right, so you can see here that they actually initially did the marking on the right foot, but after the chlorhexidine, it disappeared. Okay, next one, please. Okay, the safe surgery checklist was filled as right TKR and site of operation was confirmed with patient's daughter. So everything was in order. And they even confirmed with the patient's daughter before sending to OT. And the skin prep on right knee was not done in the ward. So, however, the staff actually wrapped the right knee with green towel. Basically, it indicates right knee need to be operated. So they wrapped the right knee. So, however, there was a mistake in OT list. It says that right knee OA, but planned for left TKR. Somehow there was a mistake in the writing. And the staff nurse, however, didn't cross-check the OT list with the consent. Next one, please. So in OT, the skin prep was done by MA, and unfortunately, the MA also didn't check the consent or the case notes and only look at the OT list. And he actually prepared the left knee because the right knee was wrapped. So he thought that the left knee needed surgery. So basically, there's a miscommunication. One person actually wrapped the intended side to be operated, but the other person thought that the one left, unwrapped is the one that needs surgery. So the house officer actually written on the whiteboard as per OT list, without verifying with the consent. Timeout was done, but again, nobody actually realized the mistake properly was not done properly. And the left knee was operated. And they only noticed they make a mistake because the implant was not suitable because the implant was for the right side. So this is a very unfortunate event, that should not happen. We went through all the process, the timeout, but again, nobody realized the mistake. Next one, please. So the surgery was stopped and they also reconfirmed with the consent. So the HOD was informed and the HOD asked them to stop the surgery and explain to the patient and family regarding the error. They actually want to proceed with the right knee TKR. So they actually close the left knee and later proceed with the right TKR. Right, next one, please. Right, so these are all, the documents are all correct. They have all the consent form, everything was written correctly. Even the safe surgery also was checked. The checklist, everything was written correctly. Yeah, but unfortunately it happened. Okay, next one. Right, so this is the last case. This is about 8-year-old boy with a right assisted hydrocele admitted to daycare surgery for right herniatomy, and the patient was scheduled for second case. However, he was brought into the OT as first case. Yeah? So the consent was not completed, and no countersign and no witness. So the staff nurse also is a new staff nurse working on first day at daycare. So she sent the patient to OT and did not inform the OT nurse that the patient is supposed to be the second case on the list. Yeah, because on that particular day, the OT list was not displayed at the airlock because it was not prepared by the staff. So again, you can see that there are many issues related to the system. Yeah. Failure of the system. So the OT nurse also accepted the patient without referring to OT list, and the HO wrote on whiteboard detail of first case and not second case. So everybody thought that this is the first case, yeah? Not knowing that this is actually the second case. Timeout session was not done properly, and this mainly because the staff was not paying attention when the houseman read out details of the patient on the whiteboard, and the staff actually did not realize the importance of timeout, and no emphasis has been given on the importance of timeout by the superiors as well. So GA was given to patient without surgeon in OT, and surgeon arrived and performed right herniatomy and circumcision instead of right herniatomy. And luckily, this is actually a Malay boy. So having circumcision, I suppose is not a problem. Yeah, but ethically it's wrong. Yeah, doing something without consent. Right. Okay. Next one. Right, so these are the contributing factors based on root cause analysis report of, why wrong surgery happened, lack of knowledge on safe surgery program, ineffective use of checklists. I think we have demonstrated that many times in the cases, yeah. Operating without knowing the patient, non-involvement of other team members during timeout, failure to communicate, refer to what written in the whiteboard only without verifying it with the OT list or the consent or the X-ray, yeah, the radiology image, and taking consent last minute, yeah, lack of supervision, human factors as well, yeah, fatigue and stress and long working hours. Next one, please. So when talking about unintended retained foreign bodies, these are some of the contributing factors that we found based on our root cause analysis when hospital, because in Ministry of Health, when incident happened, they send the root cause analysis report to us. So these are some of the findings. Yeah. So failure to do swab count properly, pre and post surgery, failure to document any inserted gauze or tampon in the patient's case note, especially after delivery, leading to staff forgetting to remove them before discharge, inadequate passing over of information or miscommunication between staff during procedure, and staff managing patient in the ward post-surgery. And the surgeon sometimes took the swab by himself during procedure and failed to inform the scrub nurse or other relevant staff. Next one, please. All right, so I just go through this very briefly, yeah, how to improve surgical safety. Next one, please. So definitely the use of safe surgery, safe life is very, safe life checklist is very important. Yeah, Mr. Anwar will talk about it later. So it's a very simple, efficient priority check. Yeah, ensure consistency in patient safety during surgery. Next one, please. So these are the checklists. Yeah, we have four elements in the primary team checklist. Next one. Next one. Right, okay. We also, in our second version of guideline, we also added multidisciplinary checklist if the surgery involve multidisciplines. Next one. Right, so this is, and we came out with a DG circular also in 2018, and which highlight all the important elements that need to be implemented, yeah, in all healthcare facilities conducting surgery. Next one. Right, so I just want to highlight this very, very important because not many people knows about this. Actually, when we started Malaysian Patient Safety Goal in 2013, all hospitals also must have patient safety committee, and this must be chaired by the hospital director. Yeah, so the Safe Surgery, Safe Life Committee in hospital should be part of this committee to discuss issues related to surgical safety. And some hospitals also have incident reporting committee. Yeah, next one, please. So these are the details. You can look at the guideline for the details, and this is the governance structure of Safe Surgery, Safe Life Committee. Next one. So I think why Safe Surgery program not working, these are some of the feedback from hospitals that I would like to highlight. Some people actually, some staff deny the benefit of the checklist. They don't trust in the checklist, yeah. And then maybe also they are very unfamiliar with the checklist, or the checklist is just a tick box exercise, yeah. And that, for me, this is very much related to the training. So we must make sure that our training, we cover, you know, all staff doing surgery, and also it should be effective. Yeah. Next one, please. So these are also findings from UK, you know, why they fail. Yes, staff resisted or failed to complete the checklist. And some said that it's actually inappropriate or illogical. And some said that it's actually a waste of time. Next one, please. Right, so what should we do now? Next one. Right, so for me, this is very important. We need to be the game changer. Yeah, we need to be the game changer. We need to be the agent to improve surgery, to make sure it is safe. Yeah, we need to train our staff effectively, have a good teamwork, and we need to speak up. If something is not right, please speak up, yeah, for patient safety. And we need to report the incident and do the analysis, do root cause analysis, and take remedial actions. And we also need to allocate resource to improve our system. Next one. Next one, please. All right, these are some of the guidelines that we produce, and all these are actually available in our Patient Safety Council. Just ask Pakcik Google, you know, Patient Safety Council Malaysia, and you can get access to all these guidelines. You can download it for free. Yeah, so we actually implement safe surgery in our patient, part of our patient safety goal, part of the houseman training, yeah, our incident reporting, and also we have revised it recently in 2018, our guideline. Yeah, so it's all available for free. Please do have access to it. And we also have some presentation and stuff as well that you can use for training. Next one, please. So in summary, these are some of the things that I would like to highlight, yeah, today. Misadventures in surgery involve lots of human factors issues and demonstrate the failure of our system. For example, the failure to actually train our staff effectively, failure of teamwork, and failure to speak up on patient safety. Yeah. So I think we really need to relook at these areas. Yeah. In order to use safe surgery checklist effectively, we need to work in team. We need to communicate to prevent individual at the sharp end from making mistakes. Actually, you know, when I talk about all the case, you know, when I presented the cases, you can see actually there are many points of failures. Yeah, actually there are many barriers to to prevent all these failures, but actually we for example, we didn't comply, or we don't know, or we don't care, yeah, and that leads to the final error, yeah. So speak up for patient safety and critical information that need to be verified at multiple points. That's very, very important. The patient identification, type of procedure, site of surgery, implant for which patient, for which site, right or left, yeah. And we need to help each other in preventing harm to patient. Yes, and all of us need to be the game changer. We need to be the agent in improving safe surgery and patient safety as a whole. Next one, please. Right, so this is our team when we actually revised the second edition. Yeah, some already retired. Yeah, Dato Jamil is not there anymore. He's already retired from this field. Okay, next one, please. Right, this is our website. So please do have a look and have access to all the training and promotional material. That's about all from me. Thank you very much for your attention. We cannot hear.
All right, okay. Sorry,
Right.
the mic was muted. Sorry. Terima kasih banyak-banyak Dr. Nur Aisyah. A very detailed and then an interesting example of the burden when we, misadventures in peri-operative care, especially with patient safety being compromised. Because the checklist is always complete. The problem is that implementing the checklist. So it takes attitude and for us to be part of the system. So it's not workable if you only have a checklist but nobody check or perform a proper systematic and then really takes part in the system. So the system now with that I will leave for the next speaker. We have the person who is the chairman of the Safe Surgery, Safe Life Steering Committee from Ministry of Health, which is Datuk Dr. Muhammad Anwar Hau Abdullah, for our next session. For the meantime, we'll take about 1 minute break, 2 minutes break basically, 1 minute for the QR code to be scanned, and you can snap the photo of the QR code for registration later. I know there are some problems trying to register. We have so many viewers today. We have close to 1,000 viewers for the day, and we did have some glitches, but don't worry, you just make sure that you snap the photo of the QR code. You can try to register later. We will collect your data for the CPD points. Don't worry about it. Yeah, just keep it in your phone, and then you can register later. We're going to have a break for our sponsor today. Okey. So kita akan ke sesi seterusnya, ceramah yang ketiga pada ini, yang terakhir pada hari ini, dan ini adalah antara ceramah yang basically the talk, the gist of the talk of the day pada hari ini. So ingin saya perkenalkan untuk penceramah yang seterusnya. Kita akan bersama dengan Datuk Dr. Muhammad Anwar Hau Abdullah, Chairman Safe Surgery, Saves Lives, Steering Committee atau Jawatan Kuasa Pemandu Kementerian Kesihatan Malaysia. Beliau merupakan seorang konsultan orthopedic surgeon yang juga sebelum ini pernah menjadi saya punya ketua jabatan di Hospital Raja Perempuan Zainab II Kota Baru sewaktu saya menjalani latihan pegawai perubatan siswaza. Dan saya amat gembira pada hari ini dapat berjumpa kembali beliau walaupun secara maya, secara online. So jadi kita pada hari ini akan mendengar topik yang akan disampaikan oleh Datuk Dr. Muhammad Anwar Hau, iaitu Safe Surgery Saves Lives Initiative, the story behind the checklist and how to fill it up properly. Dan Datuk Dr. Muhammad Anwar Hau merupakan international speaker for various conferences, editor board for Malaysian Orthopedic Journal, profit writer, author, and also very active involvement in fellowship and master program for the country, dan juga POMR assessor. Beliau berkelulusan daripada Universiti Malaya dan kemudian melanjutkan pelajaran sebagai masters di Universiti Sains Malaysia. Untuk tidak membuang masa, saya menjemput dan mempersilakan Datuk Dr. Muhammad Anwar Hau Abdullah, Chairman SSSL Steering Committee, untuk menyampaikan syarahan beliau.
Terima kasih pengerusi majlis, iaitu very nice to meet you again, to see your face, Lieutenant Colonel Dr. Ahmad Tamizi. Masih muda, masih handsome lagi. Okey, saya dah makin berumur. Okey, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Lieutenant General Datuk Pahlawan Dr. Muhammad Amin bin Muslan, iaitu Ketua Perkhidmatan Pengarah Perkhidmatan Kesihatan Angkatan Tentera, Dr. Nur Aisyah, dan juga para jemputan dan semua ketua-ketua unit, ketua-ketua jabatan, tuan-tuan dan puan-puan yang dihadiri sekarang. Terlebih dahulu saya ucapkan jutaan terima kasih kepada Angkatan Tentera kerana sudi menjemput saya untuk berkongsi pengalaman saya dalam Safe Surgery Save Life, terutama talk about the checklist. Yang kedua, saya juga mengambil kesempatan ini untuk mengucapkan tahniah setinggi-tinggi tahniah kepada Angkatan Tentera kerana telah mengadakan program ini, walaupun dia adalah webinar, iaitu di inaugural Military Safe Surgery Save Life Seminar 2020. Tajuk 2020, kita fahamlah kenapa dia jadi 2021 kan. Okay, now saya akan share screen. Seperti apa yang Dr. Aisyah presented, I will share a few kisah benar. This is from my side. Okay, a 14-year-old girl, school girl, actually she is a staff daughter, underwent planned corrective surgery for her right congenital ptosis. While in the recovery room, her mother wondered why the dressing was on the left eye and not on the right side. A 58-year-old gentleman with bilateral knee osteoarthritis was planned for right knee arthroscopic debridement and intra-articular injection, but unfortunately post-op noted left knee was operated instead of the right knee. A 25-year-old gentleman scheduled for decompression and stabilizations of the TV spine, and after the skin incision was made, the anesthetist realized that the patient's blood group was O negative, which was at that time not available in the blood bank. Patient actually need about 3 to 4 pints of blood. And after intensely discussed with the relative, the skin was closed and the surgery was rescheduled to a later date. A 45-year-old lady presented with recurrent abdominal pain 1 month post-right ovary cystectomy. So she underwent a CT scan abdomen and noted presence of a mass suggestive of tumor. And then later on, she underwent laparotomy, finding was presence of a gossipioma. So I hope you all understand what is this gossipioma. And this is the X-ray show that the what they call unintended retentions of foreign body. Therefore, ladies and gentlemen, we can see that there are multiple what they call a negative incident reported. Dr. Aisha had presented just now, and now these are some example, and these are the newspaper cutout. And later, this is one of the latest in Nigeria, where 2 cases were reported in a trauma patient. So, ladies and gentlemen, it was in 2008 under the WHO. They did a study and they noticed that the whole year there were 2,340 million operations were done globally each year. Okay, this was reported in a Lancet 2008. 234,000. And out of this 234,000 operation, they noted that the complication rate was 3 to 16%. And that made up to about 7 million complications. And the death rate due to the surgery was 0.4 to 0.8%, and they made up to about 1 million. Therefore, the WHO recognized that there were 3 main problems in surgical safety. One is it is being unrecognized as a public health issue. Number 2, lack of data on surgery and outcomes. And number 3, failure to use existing safety know-how. And the burdens of surgical disease, in fact, is increasing. More and more people will need to undergo surgery. And likewise, some of us, especially myself, when I get older, the risk I need to undergo surgery may be even higher. Okay, the reason is because our life expectancies are now more and more prolonged. And second thing, with the expansions of knowledge and technology as well as the technique. Okay, so and more subspecialty complex surgery are being performed nowadays. How about in Malaysia? In Malaysia, there was this is the figure in the 2010. In Malaysia, we performed about 913,000 surgery. Based on the same complication rate as well as the death rate as reported by WHO, we can see that in 2010, the number of deaths may be as high as 90,000. Okay, and the complication rate may be 40 to 50,000. Sorry, terbalik. The complications 90,000 and the death was 4 to 5,000. And in 2016, with the 1.1 million surgery being performed, we expect to have the complication rate of close to 100,000 cases, as well as the death in between 5 to 6,000. This is the very, very conservative estimation. Okay, and this is based on the WHO data. And then problem number 2 is the lack of data on surgery and outcome. This is recognized by the WHO. We know ONG has got very, very what you call a good maternal mortality review. However, prior to this, many surgical discipline and what you call a department do not have a very good or a very diligent surveillance. And likewise, we are also lack of data. Okay. and failure to use existing safety know-how. The high rates of preventable surgical infection result from inconsistent timings of antibiotic prophylaxis. Anesthetic complications are reported to be 100 to 1,000 times higher in countries that do not adhere to monitoring standard. And wrong patient, wrong site operation persists despite the high publicities of such events. So all this has been reported and recognized by the WHO. Because of that, WHO have came up with a strategy, promotions of surgical safety as a public health. So number 2, creations of a checklist to improve the standards of surgical safety. That's why how the surgical safety checklist come about, and collections of surgical vital statistics. And that's why after the launching of this surgical safety checklist, a lot of countries started to collect the vital statistic. Likewise, our country has been collecting a lot of surgical vital statistic many years ago. And these are the objective of the safe surgery, safe life by the WHO. Basically, is for the patient safety, to prevent wrong patient, wrong site surgery, and to prevent anesthetic harm, to prevent surgical harm, and so on and so forth. So I think I'm not going to run through this. And ladies and gentlemen, many of us were asked, and I've been asked before, because many of us has been doing things of many years without any problem, kan? Ramai daripada kita dah terlibat dalam pembedahan bertahun-tahun. Saya dah 30 tahun terlibat operation. I will ask, why must I do all this? It never went wrong for me. Okay, so however, ladies and gentlemen, the checklist will help us to do all the right thing on all patients and all the right time. Okay, you never know, things may happen. And this is the first edition of WHO checklist. Okay, and it is just one page sahaja, satu muka surat sahaja. And what is the problem does this checklist address? WHO say that this checklist will correct the patient so that we will perform on the correct patient, operation and operative site, safe anesthesia and resuscitation, minimize risks of infection, as well as effective teamwork. And after the introductions of this checklist, and WHO has done what they call a pilot study in 8 countries, Canada, UK, Jordan, Philippines, New Zealand, India, Tanzania, as well as the USA. So in the advanced, in the developed country, as well as some underdeveloped countries. And this is what they found. In 8 countries, the total number of surgery was 3,000, more than 3,000, and checklist used was close to 4,000. And they noticed that you see the p-value. Cuba tengok p-value. All the p-value was less than 0.05. They mean that the improvements were significant. Okay, in terms of death, in terms of complication, in terms of reduction in surgical site infection, as well as in reduction in unplanned reoperation. All were statistically significantly reduced. And these changes, this improvement is not only in a high income group, it also happened in a low as well as the middle income group. The changes, the improvements were statistically significant. So based on the checklist itself, the final report was that it was found to reduce the rate of post-op complication and death by more than 1/3. Okay, so WHO subsequently came out with a goal, Safe Surgery, Safe Lives Program goal, where they want to at least enroll to 250 hospitals by the 2010, and a hospital representing 1/4 of the world's population by 2009, and representing half of the world's population by 2010, and collect data. Okay, as I always said, the only thing speaks for us is data. We need to have very good data. And with the good data, a lot of things we can come up with the data, a lot of the measure recommendations and what they call a corrective measure can be done. Without data, nothing nothing we can do. And with that, we hope at least half of this complication as well as the death rate can be prevented. Ladies and gentlemen, now I add on, in terms of surgery, I think in terms of surgery, there are many things can go wrong. But what are the higher risks of adverse event? What are the situation where the adverse event, a situation where it carries even higher adverse event? And I think the one is the emergency surgery. As you know, emergency surgery is unplanned, not like the elective surgery or even semi-emergency surgery we can plan. Emergency surgery we cannot plan. Anything can go wrong. Laterality. What do you mean by laterality? Every one of us have a left and right hand, left and right leg, left and right testis, kidney, brain, and so ear, eye. So this is one of the crucial points. That's why the marking must be there. That's why the marking must be there, because we can incidentally operate. I think the incident we showed just now, left operate on the right, right operate on the left, and so on and so forth. Multiple procedure. That is another situation where many things can go wrong. Multiple teams involved. Especially when multiple teams involved, every team will just look at their own problem. Every team will just concentrate on their own problem. At the end, what happened to the problem in between? Nobody really care. Okay, team changing. Ini yang selalu berlaku. Team changing. Okay, and then odd hour. Odd hours means that in the early morning, in the public holiday, and things like that, and pressures of time. Okay, and the pressures of time. And another thing which I did not list here is I noticed lately, because of the technology, the presence of the handphone, I noticed a lot of people are using handphone in the operating theater. Okay, especially I'm very worried, especially my runner who is busy answering the handphone, and that can make what they call things can go wrong, especially when you are doing counting and checking the equipment, the number of equipment and things like that. And what are the types of patients where carry higher risk where things may go wrong? Colleagues and staff. Why? Friend, close relative. Why? Because kadang-kadang kita ni, alah, okay lah, everything okay lah kan. Why? Because you're my friend, because you are my close relative. Sometimes we try to bypass the system, the checking system, and so on and so forth. Bypass the procedure. So these are the groups of patients which carry the risk of things go wrong. Fussy patient, VI patient, VIP or VVIP patient. Okay, so these are another groups of patients which I notice that sometimes, we try to make people happy. We don't want to be too what they call too detailed, and things go wrong. Okay, because of all this, WHO have launched the Safe Surgery, Save Life as the second global patient safety challenge in the 25th of June 2008 in Washington. And of course, our country, negara kita, was represented by the presidents of the College of Surgeons and attended the event and have signed the pledge that we, Malaysia, will also embark on this Safe Surgery, Save Life program. Okay, with that, our country went on and planned. And of course, the first chairman was Dato' Jamil. I think many of you knows him. And he was the first chairman, and Dr. Aisha and myself, we were members of the committee. And after the what you call presented to the tindakan khas KPK, which is Ketua Pengarah Kesihatan Malaysia, and adopted that Malaysia, we will what they call start the Safe Surgery, Save Life initiative. And this is the very first circular Perkeling Ketua Pengarah Kesihatan Malaysia came out in the 12th November 2009, and this is where they start the beginning of the Safe Surgery, Save Life in Malaysia. And this is, I think Dr. Aisha has shown you all, this is the very first what they call guide came out. This is, we call it implementation guide on a Safe Surgery, Save Life initiative. Okay, and this is the very first versions of checklist. Ini adalah versi pertama borang SSSL. Okay, I think some of you may have seen it before. And this is the modified, upgraded first version of checklist. Okay, so the color is slightly different. Okay, but it's all the same inside there, except there's some modification lagi. Okay, and what about the feature? What is the feature about our Malaysian Safe Surgery Safe Life checklist? The feature is that kita tambahkan tema. The tema is safe surgery through better communication, which is here. You can see here, down bottom here in the last page of the form, is a safe surgery through better communication, which was not in the WHO. And in this form, WHO is only 1 page, but our form 4 muka surat. Why? Because we incorporate other existing forms into one. For example, we incorporate the swab count, a ward pre-transfer checklist, pre-discharge checklist into as one. So it became a 4 pages checklist. Okay, WHO has only 1 page. And then we also add on the scoring for audit purposes. You can notice here, ladies and gentlemen, in India, this is a scoring system. And this scoring system we add on so that in the purpose is for audit. Okay, and how we audit, that is another long story later. Okay, and then we also have the space for incident reporting. Okay, we add on the incident reporting so that anybody can report anything during this, anything happened during the surgery. For example, intraoperatively, suddenly the aircon, OT aircon went out, or the temperature or humidity suddenly climb up. So we can report it. Okay, because all these checklists will be in patient's BHT, also called the record. And in future, anything went wrong, then we can check the checklist, and then we can see, we can notice what we can know what were the incident happen, or is there any equipment failure during intraoperatively. So we purposely add in this, and we also have the specimen sent in case that post-op notes, the houseman forgotten to enter the data into the post-op note. So in this checklist, we also have included the specimen sent. Okay, and other measures introduced by us is the whiteboard in the operating theater. I think Dr. Aisha did mention and say that about the whiteboard. The purpose of whiteboard is so that we will enter patient's particular, surgeon's particular, what they call surgeon, as well as assistant particular, what called the name, anesthetist team, as well as a scrub nurse and runner. Okay, all the names will be written on the whiteboard. Likewise, the diagnosis as well as the intended procedure. So basically, when we talk about Swiss cheese, this is where we add on another defense level of defense. Bermakna, during time out and sign in, we have to check besides the checklist, we also have to write on the whiteboard, so to make sure things went on correctly. One, and second thing, on the whiteboard, we also document the tourniquet time, the tourniquet pressure, especially in orthopedic, we use a lot of tourniquet, so that we want to know how long and what was the tourniquet pressure before that we overlook and ended up, patient may ended up with the limb ischemia. Okay, we also want to know whoever walk into the OR will know what is going on, rather than not pick and see and tengok, tanya and things like that. So there's a lot of things about this checklist, and last but not least, so that every team member know each other. Okay, we know who is the name of the scrub nurse, who is the anesthetist, and so on and so forth. An important step in this checklist, ladies and gentlemen, I think based on the WHO, I think, and after we have incorporated all the other checklists inside there, you will notice the important step in this, our Malaysian safe surgery checklist is the number 1. We have a pre-op and pre-transfer check. And this pre-op and pre-transfer check is all done by the ward staff as well as the OT staff, the airlock staff. Of course, Important step is sign in. Another important step where Dr. Aisha mentioned was time out. Okay, check in, intra-op communication, sign out debriefing, inform relatives, and this is optional but prefer. Okay, a lot of us would like to inform relatives, especially when it's involved a long, complex surgery. I think those who have experience as a relative, the relative or parents underwent surgery, especially the long and the complex surgery, the outside, while waiting outside the operating theater, I think is not a pleasant experience. So it's very nice if the surgeon can just walk out and say regular, what they call interval, and say everything went on smoothly, and the patient, what they call your father or your mother is stable and not much blood loss and things like that. I think we will be very, very happy to hear that. And a pre-discharge check, okay? So these are the important steps in our safe surgery checklist. And I've shown the first edition with the modifications of first edition. And then as Dr. Aisha mentioned, in 2018, we further improved the checklist. And we also have come out with the second safe surgery, safe lives guideline. And this is the event where the Tan Sri DG, the KKM DG, launched the book. Okay, and this is the picture during the what they call the committee member for the launching event. And because of that, and the new reinforced circular have came out in 2018. Okay, what is the difference of in the second edition Safe Surgery, Safe Life? Of course, it is improvement from the first edition, and it's based on the feedback from various categories of implementer. The implementer means from the staff nurses in the ward, staff nurses in the OR, staff nurses, scrub nurse, runner, as well as the surgeon, houseman, and so on and so forth, anesthetist. And there are two sets of checklists as mentioned. First set is 4 pages, which is primary team, and second set is 2 pages only, which is when involved the multidisciplinary team. Ladies and gentlemen, why the second set came out was that if your hospital, if the Angkatan Tentera Hospital, you have a central record, everything is enter one single record, then that's fine. But unfortunately, in Ministry of Health, many hospitals do not have central record. So bermakna patient's record will be split into multidiscipline. If the patient is in surgery, there will be one record. If the patient transfer to orthopedic, will be another record. If the patient transfer to another department, there will be another record. So what happened to this checklist? What happened to this checklist? If we only one set of checklists, where are we going to put this checklist? Because the patient may have operated by 3 different teams. And where do we put this checklist? In future, if the checklist is in the surgical notes and orthopedic not check anything, we may not be able to check. Okay, things like that. And in Kota Baru, you know, selalu banjir, and sometimes the record also rosak. And that is why we introduced the second set, which is 2 pages, whereby the primary team will keep the first set, the 4 pages, and the second team comes in, we have 2 pages, and this 2 pages checklist will be kept by the subsequent respective surgical team, so that we will have the own the record for the patient. And the checklist used for all and must be used for all surgical procedure performed in operating theater, including the LA cases, local anesthesia cases. And we want and must use 2 identification. Why 2 identification? What are the 2 identification? Which is patient's registration number, hospital registration number, as well as IC number, our identity card, ataupun my card, passport, or UNHCR number, and so on and so forth. The reason is two identifier is so that things will not go wrong. If we use one number, sometimes things can still go wrong. If we use 2 identifier, we hope will be more safety level will be higher. And date format. Previously, tulis no date format. The people, you just put any format they like. Now we have determined and we decided the date format should be day, month, and year. Because why? To avoid misunderstanding, to avoid mistake in the date. Time 24 hours. As you know, if you use 12 hours the principle, sometimes AM you can mistaken written as Prime Minister, okay, or Prime Minister, you go and write AM and things like that. And this thing happen very frequently, not only in the operating notes, also happen in the patient's record documentation and things like that. So we say must use 24 hours format. I think in Angkatan Tentera is not an issue. I think Angkatan Tentera is all using the 24 hours format. And time out, okay. Issue of time out is after induction before surgical incision. This is the recommended by the WHO. However, in Ministry of Health, we also accept that time out before induction. Time out before induction, okay? Because especially my hospital in Kota Baru, many of time we practice time out before induction. That means sign in also before, of course, sign in before induction, time out before induction, so that we want the patient to participate in the time out process. And likewise, ladies and gentlemen, sign in and time out, we also say that can be performed together to save time. Okay, we will see that later. And one important note, ladies and gentlemen, to share with you all is that we put it in our guide. It is the responsibility of surgical team leader to participate and ensure the usage of this checklist. Why? Because we notice this checklist basically sort of is used by these nurses only. A lot of time, our surgeon, our specialists, not very keen in this. So in our guide, we purposely and we specifically put it in that it's the responsibility of this team leader. It is also responsibility of checklist coordinator to ensure checklist complete and mandatory to use the checklist regardless of situation. Okay. Okay, as I mentioned, must be done before induction of anesthesia, except patient already intubated. For example, kalau patient daripada ED, emergency department dah intubated, then of course lah, no, patient is already intubated. Otherwise, sign in should be done before induction. And timeout, WHO must be done before skin incision, but optional kalau boleh before induction. Okay. And another words of caution, ladies and gentlemen, is shout out. Beware the patient who is not under general anesthesia is aware of all the shouting. So berhati-hati, and sometimes patient under spinal or under epidural, kita kena berhati-hati because what we say, what our joke sometimes may not be acceptable by the patient. Okay, even patient under general anesthesia, sometimes the general anesthesia may not deep enough, and patient may still able to hear or even feel the pain. Incidences, okay, so please record all sorts of incidences in the form. And this is a checklist. Okay, so this is a checklist. You can see this is a pre-op checklist, pre-transfer checklist. Okay, I will explain detail. Okay, and this is the guideline yang second edition yang Dr. Aisyah kata tadi, you can download in the website, through the website. Okay, and what is the advantage of using this checklist? Is customized. Kita boleh modify. All of you are welcome to modify your checklist, but the basic asas element of checklist must be there. Make sure the elements of all the important elements are there, and subsequently you can modify. And we have Sabah, our colleague in Sabah, they have even modified the language based on the Sabahan language, because a local language sometimes some people don't understand. Supported by the evidence and evaluate in diverse setting around the world. It has been evaluated, promoted, and minimal resources. Just a form, tak payah. This is not a rocket science, or this is not a very costly thing, just form. Okay, so how effective is this SSL checklist, surgical checklist? I've looked through, and these are some of the report. in a various journal. Effects of surgical checklist. Okay, there were 20 studies by this report in 2012, and relative improvements of perioperative mortality by 47 to 62%, and improvements of morbidity by 36 to 37%. Okay. And conclusion is that support the checklist, but the checklist, important conclusion, should be understood not merely as a list of items to be checked. Ini yang Lieutenant Colonel Dr. Ahmad Tamizi cakap tadi. No, checklist nampak lengkap, but are they really properly done or not? Ini yang penting. Kita bukannya hanya tick sahaja, but has to be properly done. But and so the checklist must be used as an instrument for improvement, communication, teamwork, safety, culture in operating theatre. It should be implemented accordingly. This is another what we call report, and the report say introducing surgical checklist is not as straightforward. Ladies and gentlemen, walaupun checklist nampak straightforward, but it's not as straightforward as you think. And we have experience. Okay, as I mentioned just now, some of the surgeon doesn't want to get involved. Some of the staff say this ala remeh temeh, and some even say this is a waste of time. Okay, so actually to introduce and to implement the checklist properly, you really need the leadership. You need the leadership. Okay, and sometimes you need to be a bit flexible, and of course, do not. Last but not least is the teamwork. Everybody must participate involved. If not, will fail. And the surgical, does this checklist improve the teamwork? The evidence suggests checklist improve and things like that. Okay, however, in this article mentioned that the evidence would also suggest that when used suboptimally, kalau tidak digunakan dengan optima ataupun tidak digunakan dengan betul, or when individual have not bought into the process, no, dia hanya buat sambil lewa, checklist may conversely have a negative impact on the functions of the team. So ladies and gentlemen, be aware. Checklist is good, but have to do it properly. Kalau tidak, may have a negative impact. Okay. And what is the recent development from the WHO? And WHO recently have even patient for patient safety. They mean dia nak engagement, empower patient involved in patient safety. Okay, that is why some of us have what they call the induction. The checklist is done before patient under. Okay, and WHO about 2 or 3 years ago came out a new form, a patient information for surgical checklist, and this is also you can download in the WHO website, and you can modify based on our setup, and dari segi bahasa pun, and so that we can also involve patient. So we have give this to the patient before surgery and after surgery. So dia akan tanya kita soalan, so that's a double check, so that kita jawab, kita buat what has been what is necessary for the patient this after surgery. Okay, all this you can download in the WHO website. Okay, ladies and gentlemen, next, so this Dr. Aisha presented, and this is I also took this from Dr. Aisha's previous slide about the journey of the safe surgery, save life in Malaysia. Next, how to fill this form. I think to fill this form, I think most of you are very familiar dah guna borang ini. As I said, pre-op checklist here, you need 2 identifier. Nama ni kalau orang kita ramai orang nama sama. Okay, ramai orang sama. Ali bin Ahmad, Muhammad Ali bin Ismail. Many of us have this the same name. So very important, nama kena penuh. Kadang-kadang nama sama, nama ayah je berlainan. So kena check. Of course, IC or passport number, this is what I mentioned, and the hospital registration number. This is very important, very crucial. This is very crucial. And one important thing is that contact person, contact person, next of kin. Biasanya kami ambil orang yang accompany patient to OT. Kenapa? In case anything goes wrong, ada apa-apa kita kena inform. Like this, we know who to contact, the number. Because sometimes you know the number in the patient's record may be different, and or the person may not be here, maybe somewhere else, and things like that. Okay, And pre-transfer check di sini, I think most of you are very familiar. And kami dah bonify, kami dah improve borang ini supaya senang. Kami tambah, this is the ward. The first column kotak ni, this is for the ward staff to check before they transfer the patient. Before they transfer the patient from the ward. And the second kotak ni, this is when they in the airlock. Di mana the ward staff akan check patient sekali lagi bersama dengan OT staff. Okay, so kita tak mau macam dulu satu kotak sahaja siapa nak tick. And kadang-kadang OT staff dia kata ward staff tak buat, and ward staff kata OT staff tak tick, and so on and so forth. So untuk elakkan masalah, we add on 2 kotak. One is a before patient transfer daripada ward, and second kotak here is for patient while in the airlock. And I think here you are quite familiar with this. We have to check the patient's name, of course, ID, used to identifier here, consent, gonna check consent semula, and then consent nowadays in Ministry of Health, besides surgical consent, kita ada anesthetist consent, blood transfusion consent, and photo consent. Mind you, untuk ambil gambar dalam operating theatre intraoperatively, kita perlu consent daripada pesakit. Okay, and recheck procedure, consent borang semua tu, and sites of operation, ada mark ke tak, and the sites of operation. Okay, tempat kita nak bedah. Last meal, again here, I highlight here is day, the way, the format of the date, and the 24 hours format. Okay, and of course we check that whether there's a denture, jewelry, kadang-kadang pampers, patient pakai pampers kotor pun masuk, and things like that. Okay, and this is a sambungan, and this item number 7, history of allergic, so kita check semula, and availability of implant. Kenapa availability of implant? Ini yang terutama di orthopedic and things like that. Kenapa? Banyak kali berlaku di mana patient dah masuk ke OT. Patient dah masuk ke OT tetapi implant ataupun special implant tak sampai-sampai lagi. Ataupun special implant masih di autoclave, CSSD. Jadi patient dah masuk ke OT. So sekarang kami nak pastikan bahawa implant semua sudah bersedia. Memang sudah ada. Sebab itu kita check. So sekiranya implant tidak ada, then kita akan take note and akan inform the team, and as well as the NS, that mean the patient surgery may have to hold on first. Okay, and the pre-medication, apa yang telah diberikan, blood, okay, what blood, is it group cross match, GSM and things like that, and others, and write what is available, apa yang sudah dijanji oleh blood bank. 2 pint, pack cell, 2 unit, FFP dan sebagainya. Mereka ward staff kena tulis. Okay, and case note relevant lah. Kalau patient dah 10 tahun follow up, kita tak mau nak bawa 10 tahun punya, kita nak yang latest, yang relevant and things like that. Okay, likewise imaging study, and of course BP, temperature and things like that. Okay, and this is a very important step in terms of sign in. Dalam sign in ini, inilah sepatutnya dibuat oleh anesthetist bersama dengan dia punya nurse, which is a GA nurse. So again, you see, patient akan dicek semula lagi. Confirm patient betul ke tidak, procedure betul ke tak, site, consent, operating site, GA machine. Okay, NS kena check GA machine, make sure GA machine is working. Pulse oximeter, kita tak mau tengah operate pulse oximeter tak bergerak, tak boleh baca. Allergic, difficulty airway, any group cross match ke apa-apa. Ini yang kita boleh elak daripada apa yang berlaku kepada TB spine, TB patient tadi, TB spine patient tadi yang saya kisah benar tadi. Adequate IV access, okay, suction apparatus, OT table. Kami tambah OT table check and functioning because banyak kali berlaku tengah operate, surgeon rendah, OT table tinggi. Ataupun surgeon tinggi, operating table terlalu rendah. Ataupun NS tengah nak intubate, tengah ada anything happen, NS nak intubate, OT table terlalu tinggi, tak boleh turun, and karang kabut kena macam mana nak turunkan table, macam mana nak cari what they call stool ataupun kuda untuk NS to stand and things like that. Sebab itu kami check semua ini, harus dicek, and kadang-kadang kita nak tube patient and things like that. Sebab itu kita kena check. Okay, this is sign in. Tengok sini, this is sign in. Langkah kedua adalah time out. Jadi seperti saya cakap tadi, untuk save time and untuk mengelakkan boring kan, check lagi. So kami di hospital, setengah-setengah hospital kadang-kadang kalau NS dengan surgeon semua sudah ada, kami buat together. Dua proses, dua step ini sebenarnya kita boleh buat together, which is better and kita save time. Okay, and whiteboard written. Di sini kita ada check, is the whiteboard written properly or not? Di sini nak kita, this is another safety level. Kami create another safety level, make sure everything written on the consent form, written on the checklist, and it's also the same as in the whiteboard, ataupun whiteboard is the same as consent and semua dia. Okay, so this is we add on another safety level. Introduce team member, of course lah. Introduce team member ni sound funny kan? Kita dah kerja hospital berpuluh-puluh banyak tahun sama sekali, nak introduce lagi, well, memanglah kadang-kadang kita rasa kekok nak introduce dah. Tetapi kadang-kadang kita invite orang operation ataupun ada new team member, terutama sekarang kami houseman, selalu ada houseman baru keluar masuk, at least mereka pun kenal, kita pun kenal mereka dan sebagainya. Okay. Antibiotic prophylaxis, inilah langkah yang kita boleh make sure antibiotik kalau perlu, prophylaxis kalau perlu, it was given at the appropriate time or was given. Essential imaging display, briefing. This briefing is important. We have to tell the NS what we want. Contoh orthopedic, kadang-kadang saya nak kata saya nak lateral position, saya nak semi prone, saya nak macam mana and things like that. So I have and normally we also discuss about estimated blood loss. NS review, okay, and scrub nurse review, okay. So kita kena bagi peluang kepada scrub nurse because scrub nurse is also part of the team. When we say surgical team, it's not only the surgeon and not only the NS, the scrub nurse and the runner, they are all in the team, including the attendant yang kerja di OT. Sebab attendant kadang-kadang lebih penting daripada lain. Kalau kita nak adjust lampu, kalau orang adjust, kita akan rasa frust. Apa ni? Saka sumbat, saka tak berjalan. So attendant is also very important, and that can make our surgery safe, smooth, and happy. Okay, so itu dia. And then check in. Apa makna check in dia? Sorry. Check in is Check in is so that when everything is ready, before the surgeon start cutting us for the scalpel blade, we will inform the anesthetist and the scrub nurse, can I start? I always tell my scrub nurse, hide the scalpel. Simpan your scalpel. Jangan bagi surgeon nampak. Because surgeon ni bila dah ready, kadang-kadang tangan sudah gatal, dia tak sabar, dia terus grab the scalpel blade and terus sendiri tanpa kebenaran scrub nurse. That's why I always tell the scrub nurse, sembunyikan scalpel, okay, sehingga dia surgeon minta kebenaran. Okay, so for the surgeon, I'm very sorry, but that should be the way. We cannot start when an anesthetist sometimes may be still struggling somewhere, doing something for the patient, or the scrub nurse is not ready. And when you cut, start bleeding, and then you start shouting, and the scrub nurse is not ready. Okay, so please. So check-in is to get permission and as courtesy to minta kebenaran untuk memulakan pembedahan. Intra-op, during intra-op communication, this is very important. Kalau surgical procedure yang pendek, there's nothing, no issue. However, if this is a complex surgery, if this is a long surgery, I think on and off intra-op communications is very important. We have to periodic, NS have to, NS have to assure surgeon, patient, everything is okay, semua tu, don't worry, go ahead, continue. And likewise, the surgeon have to inform the NS if the patient is bleeding or the blood looks a bit diluted, maybe the IBC set in, or if you encounter problem, you may need to take slightly longer because to settle the problem, the complication and things like that, or we need to communicate each other. Likewise, shout out. Apa maksud shout out? Shout out is that if anything happen, contoh kalau gauze jatuh, kalau equipment jatuh or fall out of the table, we have to shout out, because otherwise the scrub nurse may not know, may not be aware. Okay, beware of shout out, because as I said just now, if the patient is under spinal epidural, beware shout out. Jangan buat sampai patient pun, because patient is under spinal, patient is sedar, jangan sampai dia pun panic. Okay, so tengok keadaan. I think all of you know how to tengok keadaan and able to adjust the way kita communicate. And jangan, kalau bleed banyak pun, kalau patient under spine pun, the way kita communicate kena berhemah supaya patient tidak panik, and sehingga nanti dia pun tak selesa. And pre-closure, disclosure, this is important, because when we start cleaning the wound, kita start cleaning to the wound to prepare to close the wound, we have to inform the NS, so that NS boleh adjust anesthetist agent dia. And second thing is NS can call the next case supaya tidak tunggu lama, supaya tinggal, and don't waste time, case to case interval timing, so that we do not waste time. Okay, and sometimes we may even need to call other surgeon to come in. We may need to call other, what they call a service to come in. For example, orthopedic may need II, so that we can inform radiographer. No, we don't want the patient under baru nak call, and then kawan tu tengah minum air, kopi and things like that. So we inform them early. Okay, and so, and likewise the nurses can prepare the set, make sure the set is ready. And the last one is sign out. Sign out, this is basically the debriefing. So when we close, okay, usually at the times of closing, we will inform the team what was we will finalize the finding, we will finalize the procedure, and we will finalize what are the post-op order we need to have. Likewise, we will ask the NS, hey, patient ini perlu darah lagi ke tak, and things like that. And the nurse normally will, the runner normally will come and ask you, hey, doctor, what is the specimen, how to label, what is the specimen called, where it is, and things like that. Okay, if CNS taken, what are the specimen, make sure the specimen jangan mix up, jangan terbuang in a tong sampah and things like that. Okay, so if there's any issue, so that we can also address. I think this issue, this is a sign out ataupun debriefing. This exactly like airline. Kan bila habis tu mereka dah keluar daripada aeroplane, kadang-kadang you tengok mereka gather in one corner and they will talk to each other. And actually that is part of debriefing. Okay. And last but not least, inform relative. As I said, this is optional. Kalau long procedure, complex procedure, I think it's very good and very nice to inform relative regarding the progress of the surgery. And I, as an I'm orthopedic onco surgeon, I always also show the tumor I have removed to the relative. I always show it to them, explain to them, and let them take picture. I always allow them to take picture of the tumor which has been removed. And they are actually, many of them are very, very happy. Okay. And inilah column yang saya cakap tadi. This is a checklist. This is an issue, any incident, any checklist coordinator to sign, and this is for the auditing purposes. Auditing purposes, what we do is in the sign-in, for example, dalam sign-in ada 10 item utama, very important step in the sign-in, so it's a 10 markah. In the time-out, there are 8 important step, important element in the time-out, so itu 8 markah. So in the check-in, ada 1, in the intra-op ada 3. So, ini yang kami akan audit. Audit, you can perform in 2 aspects. One is retrospective. Retrospective audit means you retrospectively tengok borang itu tanda ke tidak and things like that. We have go ahead with the prospective study, observational study, di mana staff which is not being known to the scrub nurse, surgeon and things like that, you observe the SSL procedure in the OR. Okay, they will observe the procedure and they will quietly tandakan all those things has been done accordingly. So this is what we call optional observational auditing, and we find it is very useful. Okay, and then this is a swab count instrument. I think most of you are very aware. Okay, I think ini tak perlu elaborate lagi. So if you have add on the instrument ataupun count, you can add di sini tambah lagi. And okay, di sini ada satu kolom actual operation sebab kadang-kadang operation yang dirancang dalam consent OTD mungkin berlainan sikit, so kita boleh tambah di sini specimen send, and last you can see name of first scrub nurse, second scrub nurse, circulating nurse, semua tu sebab kadang-kadang ada involve team changes in long procedure ataupun kebetulan case dah dekat the shift, staff nurse shift nak habis dah. So involve team changes, so we can document all this inside there. Okay, and this is a discharge check. Again, I think these are quite straightforward. Again, this will be the check by the OT nurse before patients roll out from the what they call the observation bay, and this is in the airlock. Sekali lagi dua kotak. This is an airlock between the ward staff and the OT staff. So they check the patient together. Sebab dah pernah berlaku di mana patient balik ke ward, the BP is low, and the ward staff kata, well, OT nurse beritahu saya kena ambil walaupun BP low and things like that. We don't allow all this type of we call it nonsense to happen. So we have to, and one important thing is check IV line and infusion. Item number 7, number 6. It have happened before. It have happened before. We have what spinal anesthesia. Okay, the line, spinal anesthesia punya line, and infuse what they call morphine. No, accidentally dia pasang morphine infusion dalam spinal anesthesia dalam IV line tu, and things like that. What they call spinal punya tubing, and a lot of all this mistake can happen. As mentioned, we tried with all this step. Hopefully we can avoid. We can avoid pick up and avoid all the unnecessary complication and mistake. Okay, PCA pump. This is what happened. Arterial line, things like that. And another important part is here: amputated part and placenta. Have they been handled properly? Have they been sent to appropriate place? Kadang-kadang ini yang kadang-kadang reality, tiba-tiba my OT cari di mana kaki saya punya bapak, special orthopedic BKA amputation, tiba-tiba boleh datang mana saya kaki ayah saya, ataupun placenta di mana uri isteri saya. That's why it's very important we have to handle them properly, even though may not be important to us, but it is very important to the family and member. Okay, so I think that's about all. And this is the multidiscipline punya checklist. Ini multidiscipline checklist. Basically sama saja. Basically sama. Kecuali di sini lah information OR kita ringkaskan sebab kita tak mau lagi isi benda-benda yang sama daripada first page tadi. And kita terus ke ini. Okay, kita terus. And kita dah tak ada sign in. Why tak ada sign in? Because patient is already under. Okay, no more sign in. This is a second surgical team datang, patient already under, jadi dah tak ada sign in. Tetapi kalau second team come in, nak start operation, dia kena buat intra-op, what they call time out semula. Okay, for example, surgeon buat laparotomy, dah habis, auto come in to do open fracture femur. Then sebelum auto surgeon datang, must start procedure, dia kena buat time out dengan anesthetist. Okay, kita tak boleh presume and assume everything is okay. So inilah dia punya procedure, dia punya ni, and but the rest is all the same. Okay, the rest of the things is all the same. And this form will be kept in the orthopedic notes. Kalau this is a second team, kalau third team contoh come in, another team, dental team come in to do the dental fracture, then there's another form, and this. The another form will be kept in the dental punya record. This is for those hospital yang tidak ada central record, single record. This is for hospital yang multiple record yang di split into multiple discipline, and the rest is all the same. Okay, and I think I've end my talk, and I must acknowledge Dr. Nur Aisyah, okay, and Dato Jamil, because some of the slide I used their slide, and of course all the current and past steering committee member. And same picture as Dr. Aisha showed just now. Thank you very much. Okay.
Alright. Terima kasih banyak-banyak kepada Datuk Dr. Muhammad Anwar Abdullah di atas penyampaian yang begitu detail, dan kita amat berharap yang semua peserta hari ini mendapat manfaat. Jangan risau, kalau terlepas mana-mana slide tak dapat nak tangkap semua, we do have the YouTube recording ni, boleh dilayari semula, boleh dengar balik berapa kali nak dengar Datuk bercakap. And Datuk, thank you so much, it was very informative. We are very happy to have you on board with us today. Kita ada banyak juga soalan-soalan yang dimajukan untuk kita punya speaker today. One of the question, okay, saya rasa ni agak common, cumanya mungkin sama ada Datuk ataupun Dr. Aisyah ya. This one comes from I think Colonel Dr. Dr. Muhammad Badli, our psychiatrist ya. Dia tanya, kalau if patient are currently mentally stable but need emergency surgery, no relative around, who to sign the consent? I think we have this quite regularly. I mean, at any part of clinical practice, we will at one point face the situation where this condition can happen. So, and how do we approach for this, either Datuk or Dr. Aisyah?
Okay, for the patient, psychiatry patient is divided into two categories. If the patient is mentally unstable, the consent is not valid, dia tidak sesuai bagi consent. And if the patient need emergency operation, and actually Dr. Aisyah is baru ni kami pun ada discuss tentang consent. We are actually preparing a practical consent guideline for the Ministry of Health, and the guideline can be used by all parties lah, termasuk lawyer ke siapa-siapa, okay? So indeed, and we actually this guideline we also based on the MMC punya consent guide, okay? So if the patient is mentally unstable, the consent is not valid. And if the patient need emergency surgery means kalau patient punya life is at stake. Okay, kalau tak buat, patient mungkin akan meninggal. So kalau keadaan ini, ada dua orang boleh sign on behalf of the patient. One is psychiatry kena sign, because psychiatrist yang mengesahkan bahawa patient ini adalah tidak tidak sesuai bagi consent, and the psychiatry is treating psychiatry, the psychiatry who treat the patient. And the second person, of course, kalau surgeon, then surgeon who is treating the patient, who is planning the surgery, who is going to operate the patient has to sign. So they mean the two what they call qualified, registered medical professional have to sign for the patient. Kalau patient stable, consent valid, memang dia kena sign sendiri, kita tak boleh sign untuk dia.
I understand. And I think a few other questions are still coming in. I believe one of the questions has already been presented by Datuk just now. Any local international statistic regarding success of implementing SSSL? I think you have shown it in your graph just now. The success rate and also the study of implementing. It does make a difference. And that's why we are championing this as part of a standard of patient safety. And our ultimate goal, we are not trying to make things more complicated, but I think being safe is the utmost priority for any surgery, for any cases. We try not to do any wrong thing, despite things can happen. But like you said, some factors are more prone to develop problems and also occur in terms of mistakes. But then with the checklist, we try to make all standardized. And
maybe I can add on that as well. Yeah. Basically, when we look into patient safety, there are lots of like human factors element come into it. Yeah, so basically, for example, our mind is so fatigued and we are tired after been working for quite a while. Yeah, so basically, checklist, the main function of checklist is to ensure standardization and to make sure that we will not miss all the critical points or things that we need to do. So it helps with our fatigue issue, with our human factor issue. Yeah. So that's the reason why checklist is important. And the power of checklist, there are many studies being conducted related to the use of checklist and the benefit of checklist. Yeah. Thank you.
All right. Okay, I think we are towards the end of our first session today on the 12th of March. And we as an organizing committee would like to say a very big thank you to our panelists today. We have Brigadier General Dr. Muhammad Razin bin Kamaruzzaman, Head Corporate Safety Oversight Malaysia Airlines Berhad. And we have the second lecture by Dr. Nur Aisyah binti Abu Bakar, the Deputy Director Medical Care Quality Section, Medical Developmental Division of Ministry of Health Malaysia. And also we have Dr. Muhammad Anwar Hau Abdullah, Chairman, SSSL Steering Committee, Ministry of Health Malaysia. A very big thank you. We are very happy. I do hope and for your information, we have 1,200 plus registered personnel today that listening to this talk. And we are very happy. Basically, initially the programs aim at only about 100. It seems that we are oversubscribed by 12 times. It seems both of all the panelists seems very popular, I think. And we do hope that next week we're going to have the same impact. And we do hope that patient safety standards can be improved. But first of all, we must always have the right mindset. The checklist is there. We already have the system. We implement the system, and I guess we do hope that we are doing something here for our patients. And with that, I guess thank you very much, Dr. Aisyah, Dr. Anwar, and Dr. Razin.
Terima kasih.
We'll see you again soon. So the next is going to be for housekeeping announcement. We're going to promote for the next week speakers and session. We're going to have 4 more lectures by next week, also with reputable speakers from the country. And we are okay, for those who are trying to register but still cannot register, don't worry, keep the QR code, keep on registering. Sometimes we have problem with our server, but don't worry, try to register. And we do hope you guys to join us next week with this promotion. And after the promotional about next week, we're going to have our sponsors video. And then by then, I think we say goodbye to everyone. Have a good day, and we'll see you next week. Assalamualaikum. Video boleh?